Everyone, this is a pleasure to have you here in Miami with us. Finally, so many people that I have seen in years. I don't say it as a good thing or as a bad thing. It's just a fact. Welcome to Miami. As you know, we needed to postpone the meeting for next year in August 2022. We've been working hard for this meeting with the advice meeting, with the help of Manuela, Lilian, Scott Chicora, so I want to thank them all. And we're still gonna need to wait and work for another 8 to 9 months until we can meet all of us here with Ifso Miami. I want to thank the people who are here in the room. We have more than 40 rooms of people who came to Fontainebleau, so for that effort, I thank you very much, because I know it's an effort to come to Miami in these times. So I hope you have a blast, that you recover well before you travel back to your houses, to your homes. We have a very good program for today. We have 3 symposiums. For the first one, I want to thank Estuardo Pérez, Carlitos Erweg, because through the effort, Ifso Latin America create that first symposium. Then I want to thank for the second, Marina, Kurian, Rachel, that they are here. For the X Factor meeting, that it's an honor for us to have this type of symposium with us. And third one, the top 10 papers. As I mentioned before, we got more than 1,000 papers, more than 350 videos. So the scientific committee select the best top 10 papers. It's going to be presented today. They're going to be published either in obesity surgery, and my understanding is 2 of them are going to be sent to the New England Journal and to JAMA. So you will be hearing from them, and congratulations to all of them. They will be getting their certificates. These 3 symposiums are going to go presential like we are here, and they're going to go virtual. We have more than 1,200 registrants for the online session. So a lot of you will be able to listen to these sessions. They're going to be discussions here. So for that, I thank all of you. And again, Manuela, your efforts, Lilian, you guys, and we're going to start with the first symposium. I want to introduce first Dr. Estuardo Pérez, President of Ifso Latin America, that is going to start this first symposium. Estuardo.
Muchas gracias, Nathan. Thank you very much, everyone, for being here. Thank you all. You're watching us live. I want to thank Dr. Luis Poggi. He made it from Peru, and Sergio Aparicio, he made it from Bolivia, and all you guys, thank you very much for being here. So we're going to start. Thank you, Nathan, for the presentation and the good opportunity for us to be here. Hello, everyone.
Okay, we're going to begin with the first debate. We're going to talk about sleeve gastrectomy, hiatoplasty, always or selective. Dr. Juan Antonio Lopez Corvala is going to stand by always hiatoplasty. You have 5 minutes, Doctor. Anyone?
So this is going to be a good one.
Buenos días. Me dijeron que iba a ser en español porque iba a ser Latinoamérica. No, pues eso fue lo que recibí. Pues yo la traje en español pensando que era español y la mandé en español y no me dijeron nada. Bueno, el punto es de que necesitamos evidencias para decir si a todos le vamos a hacer hiatoplastía. Este es el primer artículo que nosotros publicamos, lo mandamos en el 2006-2007, donde el propósito era nada más pérdida de exceso de peso y complicaciones como la fuga. Desconocíamos el reflujo. Ha tomado mucha importancia porque la manga actualmente en el mundo es lo que más se realiza si hablamos de cirugía obesidad. Vamos a hablar de evidencias por qué se debe hacer a todo mundo hiatoplastía en caso de manga. Si empezamos con que la obesidad tiene enfermedad por reflujo porque tiene aumento de la presión intraabdominal y el gradiente de presión gastroesofágico está incrementado. Hay aumento de las relajaciones transitorias del esfínter esofágico inferior. Ese es el otro punto. Y la hernia hiatal, por lo menos en el paciente obeso, es 30%. Está incrementado el Barrett, y si está incrementado el Barrett, está incrementado también el adenocarcinoma. Ese es el otro punto. Si hablamos de manga gástrica y reflujo, para decir qué vamos a hacer y le vamos a reparar todo ese hiato, pues está por lo menos en el 50% de todos los pacientes obesos hay reflujo. No estoy hablando solo de gastrectomía vertical en manga, solo el paciente obeso. Y de los pacientes que piden cirugía, prácticamente el 70% llegan con reflujo. ¿Quién nos dio la idea de que estos pacientes tenían alteraciones del esfínter? El primer artículo fue de Italo Braghetto, donde nos mencionó que el esfínter esofágico inferior tenía alteraciones. Aquí lo podemos ver, su primer trabajo. ¿Y qué es lo que pasa cuando hacemos una gastrectomía vertical en manga? Vuelvo a decir, necesitamos evidencias para decir que a todos se les va a reparar el hiato. Primero, hay reducción de la presión del esfínter esofágico inferior. Se altera el GIS, que es una estructura antirreflujo. Hay reducción de la compliance, la distensibilidad gástrica, hay aumento de la presión intragástrica y además con un píloro intacto. Ese es el otro punto. Me fui. Perdón. Y además, dilatación de la parte superior del estómago o dejar fondo remanente es un problema para el reflujo. Las estenosis que a veces hacemos en la manga también incrementan el reflujo. Y hay hernia hiatal no reparado de nuevo, es otro problema, o alteraciones en la motilidad. Vale. Ok, yes.
Switch.
Ok, wow, wow.
Too early for you.
12. Sí. Ok. Bueno, déjame terminar con esta. Bueno, la gastrectomía, ya son 3 minutos que me quedan. La gastrectomía puede provocar erge de novo o empeorar el erge preexistente. Y desde luego, otro punto que no se ha discutido, alto índice de erge asintomático preoperatorio hasta en un 45%. Ese es el otro punto importante. Tenemos varios metaanálisis, uno de ellos que indican que el erge de novo después de manga puede ser hasta más del 20%. En este artículo, vean 3 grupos de pacientes. Unos asintomáticos y sin esofagitis, otros asintomáticos que le llaman silente con esofagitis y otros sintomáticos con esofagitis. ¿Qué pasó en los sintomáticos con esofagitis? Se duplicaron. Los que no tenían síntomas, tenían esofagitis, se incrementaron los síntomas. Y en los que no tenían ni síntomas de esofagitis, también se incrementaron. En este otro estudio de más de 10,000 pacientes, ¿qué pasó con el Barrett? Vamos a ver, ese es el otro punto.
1 minute.
1 minute, yes. Hubo de nuevo 23% de reflujo. Esofagitis 30%, Barrett 6%. Inhibidores de bomba tuvieron que incrementarse en un 38%. En este otro artículo estamos viendo la asociación de los que no tenían Barrett y después de manga, 20%, y en este otro artículo reciente, 17-18%. O sea, que si seguimos con esto, sin duda hay muchas evidencias que nos van a decir que hay que repararle a todos. Esto sigue muy controvertido. Vamos a ver. Sigue muy controvertido en relación al efecto de la cirugía bariátrica. Hay eje preexistente y eje poscirugía. Sigue controvertido, pero no hay duda que a todos se les debe recaparar. Hay poco conocimiento en el esófago Barrett y el adenocarcinoma. Pero dadas todas estas circunstancias y todas estas evidencias, no cabe duda que es un problema grave, es un defecto grande de la manga gástrica y se tiene que hacer otro. Se tiene que hacer algo, repararle a todos.
Thank you, Juan Antonio. Now, Dr. Nathan Sundell is going to speak about only selective, hiataloplasty only selective.
Thank you very much. I didn't even bring slide because it was too easy. I don't know who gave me this present in the morning. So, I mean, if you want me to argue anything, because I won already without even starting. So this is a very easy debate, you know. So you're gonna find a 1 centimeter hernia, you're gonna find a 2 centimeter hernia, then you're gonna dissect, you're gonna make it a 5 centimeter hernia, and then you need to close it. That I totally disagree. Whoever did reflux in the past, whoever did hernias in the past, understand that the hernia is not the most significant component for reflux. It's not even close. The presence of the angle of His in the abdomen is a factor. So if you go there, you find a 2-centimeter hernia, the angle of His is there. There is not a single reason to dissect that hiatus and close it. Because the number one complication when you close the hiatus is dysphagia for closing the hiatus. So you have to be very careful there. You cannot, everything you do has an implication in life. Most of the paper you see went for not closing anything to closing everything. And as I noticed, when the insurance companies stopped paying for the hiatal closure, there were no more 100 closure of the hiatus. They went like for 40%. So there's no reason really to do the closure of the hiatus if it's less than 2 centimeters. I'm not gonna fight the 3 centimeters, the 4 centimeters. We can fight the 5 centimeters because those one, if you don't put a mesh or if you don't use at least barbed sutures, then they're gonna open again, more than 50% in the first year. So what I will say is that close them when you need to close them. Don't create hernias that they are not there. And if you're gonna close them, don't put what I call the saliva stitches. The saliva stitches is 2 stitches they put anterior, that they are worthless. There's nothing you do with those 2 stitches anterior. They look beautiful, but they are worthless because there's nothing there that's gonna support the hiatus. If you're gonna repair the hiatus, you do a posterior dissection, you do a real dissection, and then you close it. In order to do that, they have to be a real hiatal hernia, and it has to be a real dissection that you don't need to do if it's less than 2 centimeters. I will say that if you go to the OR, you see a very small hiatal hernia, an indentation. The angle of which is in the abdomen. You do your sleeve. When you finish your sleeve, you can look posterior what is in that hiatus. And if that hiatus now look bigger, not for your dissection because maybe there was a misappreciation of the hiatal hernia, then you repair it. I also see people repair it before doing the sleeve. This is not a debate, but you need to close it after you do the sleeve, and that's my humble opinion. And our own experience is around, I don't know, 4,000 sleeves. And we only close it posterior, and we close it posterior because now I know the calibration I have to do according to my sleeve with a bougie in place. Why I'm gonna do it before, and then I'm gonna resect 80% of the stomach, and now I have it again dancing there or too tight without a bougie. So reflux, real reflux, you repair the hiatus when it's needed, you close the hiatus with a bougie in place, because you are not doing here floppy Nissen or anti-reflux measurements. You are just closing the hiatus and beg that there is no reflux after that. Or worse, they're gonna put the omentum and see if that treat the kink you already did. So I think we cannot do things that they have an implication and we don't have to do. Thank you very much. I hope I didn't spend more of my time.
Excellent. And now, Dr. Fernando Montufar, you are going to coordinate this debate. You have 5 minutes.
Fernando, vas a coordinar ahorita. Decir lo que querrás, yo te lo voy a traducir con mucho gusto. Okay? I'm going to translate for him. Preguntas. Fernando.
Doctor Juan Antonio, con respecto al tema, pues tú te basas en que siempre tiene que, digamos,
We need to repair always, always. Because we have reflux novo, we have Barrett, we have a lot of problems after sleeve gastrectomy. If you study after a sleeve gastrectomy, the stomach and the esophagus, you will have problems in reflux. You need to be careful. Now everybody is agreed that the sleeve produces reflux.
Okay. Dr. Montufar asked if always you have to repair the hernia.
Yeah, he said yes. Yeah, he said yes.
Yes.
Good. Yes. And you say, Nathan?
I said it's very easy. If you have Barrett, why the fuck you gonna do a sleeve? Closing what? You don't have to do a sleeve. If you have Barrett's, you think about what are the implications of having Barrett. If you have 75 years and you have Barrett, You can do whatever, and then you do radiofrequency, ablation, you can do whatever. But if you have Barrett, this patient has to be very well studied because repairing the hiatus is not going to prevent the Barretts to increase or to get malignant.
I'm talking about that the sleep produced Barrett. This is the point. If we operate young people, 20 years old, what happened 40 years old later? This is one of the points.
So you, Juan Antonio, you think that if you close the hiatus, there's not going to be more Barretts or reflux?
We need to do something. We need to do something. I don't know. Now we have different kind of procedures to avoid the reflux in the sleep, but we need to do something. This is the point, because the sleep produces GERD and sometimes can produce Barrett, and sometimes in the future, sooner or later, we will see cancer. This is the point.
Yeah, so in my mind, the hiatus is not the most important component of the prevention of reflux. There are studies that they will show you is more the shape of the sleeve, is more the strictures, is more the kinks, and there are very few studies. Probably the best one, it will be related to the Jorge Diaz paper saying that you can prevent reflux, but there is no real study that they will tell you prevent reflux just with the close of the hiatus. More than that, if you see the people who really do reflux, and you see the component, the publication in JAMA of Dr. Tom DeMister, in all the algorithm to surgical candidates, there is not a single mention of hiatal hernia except in one small square that it says hiatus of more than 3 centimeters. I've been conservative saying 2, it's 3 centimeters, because the hiatus is not the important component for this. For me, when I close the hiatus, is because some of the gastropericardial, gastrobronchial, and gastropleural fistulas that I saw in my life, it was because the sleeve leaked on the chest. So when the sleeve leak on the chest, the scenario is much worse than when the sleeve leak on the abdomen. But for prevention of reflux or creating a big space when you have a 1 or 2 centimeter hernia, that's what I'm not agree. That's what I say it's selective.
But the point, as soon we start to study the reflux in the sleep, and we know in this moment, every day we have more sleep with reflux. This is one of the points. We need to do something for that.
Yes. I will kill you if you close this hiatus. 2 centimeters? No. You won't be my fellow anymore.
Okay,
Okay, bye.
It's not only to close the hiatus. We need to descend the esophagus.
I'm sorry.
We need to descend the esophagus and we need to close the hiatus. Both things are important to avoid the reflux. It's not only one. But my point, if you don't close all the patients, the hiatus, you will have reflux. More than you think, I'm sure. And you will have Barrett. And sooner or later, you will have, because we operate young people, sooner or later, you will have cancer.
Please, when you vote, it's not always or never. It's always or selective. Yeah. So as you see, for the vote, it's always or selective. It's not always or never. Because never is a crazy thing. As also, always and never, there are two extremes of life.
For both of you, what size of bougie do you use if you are closing the hiatus hernia?
With the bougie?
Yes.
No, I use the same one.
Which one? No,
I use 34 or 36, depends what I'm using. I mean, sometimes when I use some that they have balloons, I use 36 because they come in 36.
Okay. La motilidad esofágica influye en que decides o no el cierre.
Fernando is asking if the motility of the esophagus will affect your decision making about the.
You have a problem with the motility of the esophagus. Maybe this patient is not candidate to sleep. This is another point because we need to understand the physiology of the esophagus. Because some of the patients, they don't need sleep. Maybe they need gastric bypass. It's another point. But if we talk about patients with correct motility, in our opinion, you need to do something to avoid the reflux. Because now, at this moment, the sleep and the reflux is very frequent, more than we think, more than 30%, more than 40%, more than 50%.
Thank you very much, Dr. Juan Antonio.
You agree that?
This is the last. It's over.
Time is over. Thank you very much,
Move on.
both of you. Next person.
So we're going to continue with the program. Our next debate will be about surgery under 35 BMI without comorbidities. This might sound crazy in some other countries, but in Latin America it's very common. And I'm strong. I believe we have to do it, but let's see what happens. So Felipe Canto from Mexico and Luciano Pollo from Peru, they're going to talk about it. So thank you for being here. El control, ¿quién lo tenía?
Dáselo a Felipe. Listo.
Okay, there's the first slide. Thank you for the invitation. I'm Felipe Cantu from Mexico. It's always a pleasure to come back to Florida, this beautiful paradise, Miami. Okay, and I'm supporting bariatric surgery in BMI below 35 without comorbidities. I have nothing to disclose. Very good. Okay. From an anatomical and metabolic perspective, the term obesity should refer to an excessive accumulation of adipose tissue. That's why the accuracy of the BMI as a determinant of body fat mass has been questioned for decades and published in several papers. A person can have a low BMI and still have a high percentage of adipose tissue and vice versa. What's wrong with this picture? Dwight Howard and the Gronkowski, they're obesity, overweight and obesity class 1. BMI is a misleading metric that discriminates by race, gender, age, fitness, and does not consider weight circumference and the most important factors, which is fat mass and fat distribution. Normal lab results does not mean that there are no comorbidities in patients with BMI below 35. The American Association of Endocrinologists guidelines states that having a BMI above 25 is a risk factor of insulin resistance, which precedes type 2 diabetes by 3 or 15 years. We need to provide an intervention at this time during the impaired glucose tolerance period before type 2 diabetes starts. And there are other diseases that can go undiagnosed in patients with class 1 obesity, like sleep apnea, even fatty liver, NASH. We can see those diseases with normal labs, and PCOS. And we're not even talking about the relationship of class 1 obesity with cardiovascular disease, cancer, or COVID-19. And what happens in the real world? What is the treatment for class 1 obesity? Diet and physical activity, lifestyle intervention, intensive lifestyle intervention. But what happens in the real world? In a study of weight change patterns in 2 years observation period of more than 170,000 subjects, only 2 and 3% achieved a moderate to high weight loss in the first 6 months. And most of the subjects experienced weight cycling, yo-yo effect, and regain between 6 months and 2 years. And there is a very strong association between obesity and the risk of death. BMI of 30 to 35, obviously with high percentage of adipose tissue per se, is a disease. So we cannot consider these individuals as healthy or without comorbidities. And how safe is bariatric surgery in this group? In obesity class 1 patients, findings on this large series from data registers, the MBS equipped, indicates that bariatric surgery in class 1 obesity is safe in patients with class 1 and a very low risk of morbidity and mortality compared to class 2 and class 3, and they're recent papers. Okay. And the position statements. The Ifso position statement declares that bariatric surgery should not be denied to class 1 obesity patients simply on the basis of the BMI. And the ASMBS has updated their consensus guidelines in 2018, stating that in the instance of failure of medical therapy to treat weight loss, bariatric surgery should be considered. In conclusions, the BMI is flawed. It's a flawed index of adiposity. Obesity class 1 is a disease, especially we consider percentage of adipose tissue. We cannot reject this group of patients. We need to do something. And ladies and gentlemen, the evidence is right here. This is the data. We together, the medical and surgical societies, we can make a better and healthier world. Thank you for your time.
Thank you, Felipe. Now Luciano will debate this point.
You guys have my presentation? I want to start saying I want to thank Ifso for the invitation. This is a very interesting topic, especially in Latin America, due that most of the surgery are not covered by insurance. So we have a lot of patients actually asking for us to perform surgery. So I'm going to try to make a point why we should not be doing surgery in patients under BMI of 35 without comorbidities. So again, setting the discussion, COVID killed 4.5 million, and obesity and cardiovascular disease killed only in 2019 around 15 million. So what are we talking about here? We're talking about the obesity is a public health threat. So we need to think in that perspective. Obesity, how do we define the severity of obesity? How do we stage obesity? And in that matter, should we actually find an appropriate treatment for each stage? And if you look at this Edmonton obesity staging system that a lot of practices are trying to use to, one of the factors is the medical problems. So we're talking about how this adipose tissue is playing a role in the comorbidities or diseases associated of each patient. So again, we have a lot of things to offer to these patients. We don't only have surgery. So what are our objectives to treat patients with obesity? To treat the obesity, but of course to treat the associated disease and potentially reduce the mortality. So that's what we want. We want healthier people. So how can we determine this, and especially what treatment for each patient? So how does mortality change with BMI? There's a lot of information stating that actually mortality does not significantly increase with obesity class 1, just after class 1. And there's even in trauma literature, a lot of evidence that shows that obesity can be even a protective factor for example, for motor vehicle accidents or even for penetrating injuries. So should we use BMI as an indicator for surgery? I think we can all agree that it's probably not perfect, but what we need to look at is what is the metabolic disease that these patients have associated. So low BMI with no comorbidity, maybe no surgery. What is the metabolic state of that patient? So obesity is a pandemic as well. How to choose the appropriate therapy? It's all about risk benefits, right? So there is a robust evidence that bariatric surgery is safe in patients with BMI under 35. But we also know that bariatric surgery is safe in higher BMI, so that's not a reason to perform a surgery. However, the aim of most studies in this BMI group was to evaluate the impact in comorbidities compared with medical therapy. And there are pretty much no studies showing that we should be doing surgery on BMI under 35 without comorbidities. So what's the cost benefit of that? So again, this is what we should put in perspective. This is a public health problem. That's what we are treating. We're trying to make our population a little bit healthier. So there's really no data to support that we should be doing surgery on patients that have no metabolic disease with BMI under 35. So as a lot of people like to say in debates, no data, no debate, right? So again, we need to prioritize our resources. How do we do that? And that's the most difficult thing to do at this point. So what patients benefit the most of bariatric surgery? Patient number 1, BMI of 35, diabetes, asthma, hip pain, hypertension, takes all this medication, and after surgery, maybe no medications. Or patient number 2, BMI 32, no medical problems, takes nothing, And of course, after surgery, the patient is going to be taking vitamins. So this is what we need to focus on. What is the cost benefit of doing surgeries? And despite our surgeries are pretty safe, they entail risk for sure. So again, we need to prioritize our resources to those who benefit the most. We can probably agree that we need to do more surgeries, but not on low BMIs without comorbidities. There are no guidelines that support surgery on BMI under 35. And even if you take a look on what Dr. Cantu present us, Ifso and ASMBS statements say that we can do surgery on BMI under 35 if they have medical problems. So that's, I think, the key point to take home. Medical problems. What is that obesity causing in that patient? And of course, obesity is a chronic disease. It will progress. But again, we have a lot of things to offer to these patients. And the holy grail to actually make even comorbidities better is actually weight loss of 7 to 10%. And we can achieve that with a lot of things and not necessarily surgery. So again, remember, especially looking at medications in the future, we have a recent trial showing that medication can achieve 15 or 18% total body weight. And again, we have a multidisciplinary team approach. I'm just finished. So if all you have is a hammer, everything will look like a nail, and we have way more than hammers. So I think this group of patients should not be considered for surgery at this point.
Thank you, Lucian. Rami, you think everyone is a hammer here?
Thank you. Thank you both. I'll give you 1 minute with that slide to debate. You want to answer, and then you'll get back 1 minute.
Okay, yeah. Well, pretty much it was the same slides that me. And I think your slides support what I said. We all agree that obesity class 1 or BMI is flawed. 46% of patients with obesity class 1 have high adipose tissue or adiposity, and they have undiagnosed disease. So there is not such a thing as no comorbidities with class 1. So obesity class 1 is a disease, it's a comorbidity.
All right.
Yeah,
Answer.
I can agree again that most patients with obesity class 1 will progress to having probably class 2 or develop medical problems. But this is a public health issue. We cannot be doing surgery or prioritizing patients with BMI under 35 if they don't represent actually a burden for actually the medical cost in our societies. So I think that's how we should look at things. And again, I'm not saying not to do anything on those patients. I think we have a lot of things to offer them. And if they don't have a good diagnosis of medical problems, we have medication. We have like cognitive behavioral therapy. We have endoscopic procedures. We have intragastric balloons. We have so many things to offer them. Why to jump to surgery? I don't think that's probably the best thing, especially cost benefit at this point.
So it looks like this is pretty useless debate. You both lost. It's 50-50. This is the first time I see both lose. So let me ask you a question. So a young woman, a BMI 31, comes to you, a no comorbidity or so-called no comorbidity, thinking of a sleeve. Okay, do you at all talk about medication, or you think she has comorbidities that just subtle, and you just go take her for a sleeve?
Yeah, probably the first step is going to be medications.
But that's not what you're saying, the point.
No, yeah, probably yes. But I think that we need to consider like bioimpedance the scales like body, SECA. We need to measure the degree of adiposity. We need to probably include insulin resistance as a real comorbidity and not wait until type 2 diabetes and HOMA indexes. There's a lot of things that we need to include in our workout, pre-work.
All right. The same thing for you, BMI 34, but really want to have a sleeve. Would you offer that at all?
Well, it would actually, in that type of patients, what we are doing is we're having a discussion with our multidisciplinary team, and a lot of times, if we recommend surgery, it has to be actually with agreement of everybody on the team. It's not the surgeon making the decision. I know. We like that. We like that. Yeah, no question. Yeah, we like that. And that's a very interesting question because I think our situation in Latin America is pretty different than the worldwide, where insurance sometimes works.
Well, I will tell you in the US, thank you. I'm asked to comment on the US. I think we're very, very far from opening the door with insurance for 30 to 35 without comorbidity. I think personally, I don't think it will ever happen.
But probably the trending.
I'm not sure I personally agree with it. 30, 35 without comorbidity, with medication. Now we have medication approved by FDA that are very, very, very effective and very safe. So, but that's why we debate. All right, let's move on.
Thank you.
Thank you so much.
Okay, thank you very much. Now, Camilo and Mariano Palermo. Camilo says Linx will grow as an option of reflux after sleep. And Mariano says Nissen sleep has become an alternative. So let's start it now. Thank you. Camilo?
Thank you very much. Very good to have.
My presentation.
Well, you can start, Mariano.
No,
Don't worry,
you
don't
can
worry.
start. It's your,
No problem.
your turn. First, Bosa.
We have the slides. Thank you very much for the opportunity to present. It's very good to have to be here again after many years. Hopefully, this will be permanent. Do we have? Okay. Next. Oh, do we have the point? Something? I think Mariano stole the point. Yeah, probably.
5 minutes.
He's trying to. Okay, this is a 22-year-old woman, did gastrectomy 4 years ago. She presented with a weight of 65 kilos, height 165, BMI 23, continuous heartburn and permanent use of acid blockers. This was her endoscopy. This is a real case. It's not, it didn't invent it, sorry. So what do we do with these patients? We're having more and more, and I totally agree with Juan Antonio that reflux is becoming a big, real issue after sleep gastrectomy. We're having many patients. This patient had 22 years. This patient had a sleep gastrectomy when she was 18, and she came with this endoscopy when she was 22. So I think we need to address these patients. How many in this room or in the virtual debate would do a bypass on a 22-year-old patient having with this type of reflux? Most of the patients would say no. They don't want to have a bypass because they believe bypass has problems. And we know that bypass is a surgery that will have other issues in the long term. Internal hernias are some things that we cannot prevent. Many of the, even after closure of the mesentery in the top left, that's a hernia of the Peterson space. Even after closing the mesentery, sometimes you can have a hernia. You can have also leaks. You can have ulcers. You can have stenosis. So that's why we need to find options. We also know that although we like to believe that sleep is going to be fantastic and nothing's going to happen, we're seeing more and more secondary things about reflux. In this paper, we saw 17% Barrett's esophagus, and it's a matter of time that reflux is going to be a problem. On the other side, we see that definitely Nissen is not going up as we thought we were going to go up. And that's because surgery and Nissen foam duplication has other issues. So compared to 1999, December, if you see it here, patients, only 0.4% of patients with GERD are having surgery. esophageal cancer incidence has grown at a very high percentage in the last 20 years basically because of reflux and the Western way of life and the Western way of having food. In this study, here's interesting, the progression of adenocarcinoma in patients under PPI therapy. Daily use of patients, they had more incidence of adenocarcinoma. So basically what we are seeing is that definitely the PPI maintenance users are in a higher risk of developing cancer because of direct carcinogenic effect and also the disruption of the microbiome and other issues. What has happened, and if we see the data, the real data of magnetic augmentations, here we see that data is very, very strong. After 1 year, 2 years, 3 years, even after 5 years, the control of heartburn, regurgitation, PPI dependence, and dissatisfactions has been very, very consistent for Linx debate. So here, if we see the, sorry. Oh, unfortunately, okay, there we are. Okay, here the pivotal studies showed definitely that the Linx procedure was consistently making results after surgery in patients with no bariatric surgery. So the point is, and I want to go here to the final slides, if I can. And this is, I want to leave this slide till the end. This is what we see in a surgery after Linx. We have a scar, and we have a scar inside the abdomen. And I totally agree on the concept that Juan Antonio said about reflux after sleep. But the problem with this is that we don't know if the sleep is going to stay in the abdomen. And that's the big point. Probably when we close the hiatus, the sleep is going to be inside the thorax, probably when the patient is in the recovery room. So basically, and this is the one to finish, Barrett has been lower in this study. This is the only study where they had 70% regression of the Barretts after Linx. And this is not even closer of what we see in Nissen patients. So what we need to do now is that we need to do a big study where we will find and we will see which is the real numbers after sleeve gastrectomy. In our unit, we have performed around 20 cases after sleeve gastrectomy. We've seen good results. However, we think that we need more data to really support on a big scale that Linx is going to be a good result after sleeve gastrectomy. Thank you.
Okay, we continue. First of all, I would like to thank Nathan. Hello, Jaime. How are you? And Carlos and all the committee for this amazing meeting. And my talk will be about Nissen sleeve. Can we put the presentation? Okay. So, I have nothing to disclose except that, wow, what happened here? Nothing to disclose except I'm a friend of this guy. And this picture was 4 hours ago. So I was preparing my presentation and he was partying. So that's my disclosure.
You took the picture, Mariano.
You
took the picture.
It's a good one. So the physiopathology of the reflux and obesity, we know we have elevated the intra-abdominal pressure, higher incidence of hiatal hernia, eating habits, and in the presentations before, the pH symmetry and the esophagitis increase after sleeve gastrectomy. and in obesity. What we have with weight loss and bariatric surgery, we decrease the intra-abdominal pressure, and of course we have dietary changes. And with the gastric bypass, we can plus the disconnection of the majority of the stomach and divert the bile distally. And with the sleeve gastrectomy, we know that we remove all the fundus, but we have disruption of the attachments in the GA junction and high pressure. We know that the sleeve gastrectomy is a high pressure tube. New techniques have been developed endoscopically, laparoscopically, and I'm gonna talk about the Nissen sleeve option. Since I have 5 minutes, I'm gonna summarize all the publications in the literature, and we can see that sleeve gastrectomy is a high pressure tube, of course, potentially refluxogenic, and the sleeve gastrectomy in patients with GERD is inferior to gastric bypass. All the hiatal hernia repairing was talked before, and GERD symptoms, is not a contraindication for sleeve gastrectomy, but we have to differentiate GERD from the disease. Of course, for GERD, we know that gastric bypass is better than sleeve gastrectomy, but we all know that gastric bypass has long-term complications, and in some patients, we have to do a sleeve gastrectomy. Sleeve gastrectomy, we know that we have the complications, the Linx complications, but in 21-23%, we have new gastroesophageal reflux, so something we have to do to improve this technique. David Noca in France proposed this technique. Here we can see the hernia. First, the hernia is corrected, is repaired, and I'm going to show you a small video of our experience. And can we put forward the video a little bit, please? First, we dissect the hiatus in these patients. Perfect. And after the repair of the hernia, we do the bulb. And if we can move forward, please. After that, we continue with the regular sleeve gastrectomy, taking care in the proximal part. So some final considerations in the sleeve gastrectomy is, we know it's a restrictive procedure. Nissen sleeve at the beginning of the experience was incriminated for not having the same results in regarding weight loss, but if we analyze, the Nissen procedure contain only air, not food. So for weight loss, it's exactly the same. And also the gastric volume is calibrated with a bougie. So at the beginning, Nissen sleeve was just indicated in patients with Barrett esophagus, but we think that in the future, it can be an option for patients to prevent GERD after sleeve gastrectomy. That's why I think Nissen sleeve has become an alternative in the bariatric surgery armamentarium. Thank you so much.
Okay, guys, this is a very interesting debate, but do you really think, Mariano, that sleeve Nissen is a good sleeve or a good Nissen?
I think it's an option, it's an alternative. Of course, I'm not gonna do routinely a Nissen sleeve in all the patients, but in some patients that we are gonna indicate a sleeve gastrectomy, it's an option in patients, of course, with GERD. Patients with GERD, the first option we will offer to the patient is a gastric bypass. We think it's better, but we have this option in our surgical.
Excuse me, I think the question is wrong. You cannot do a Nissen after sleeve. Manuela, please.
After a properly done sleeve? You mean? You mean?
No. The question there says Linx is an option for reflux after sleeve. Yes, Nissen is the alternative. There's no alternative than Nissen.
Yeah, for sure. But on the other hand, you're placing a foreign body around the GI junction.
Yes.
There are many disadvantages. We have seen many disadvantages in placing foreign bodies in that place. What are your thoughts about?
Well, I think that's a very interesting question. However, we are full of foreign bodies everywhere. Hip replacements, valves in the heart.
But after all, do you
If
think
you have other foreign bodies, that's your problem. I'm speaking about medical foreign bodies. So I think what's happened here is that is the evolution of technology. I definitely think that if you see the results in Linx after surgery for reflux compared to Nissen, it has even better quality of life because the magnetic system it's much better in other side effects of Nissen, in the ability to belch, in other things.
I don't have any doubts about
erosions have been
migrations.
Erosions and migrations have been very low and have been in the new technique based on the number of beats around the esophagus have been changing that. I think we need to be aware and get close to that, but on the data of this was approved in 2012 in the US, even before in other places around the world.
Do you think this is a permanent solution or just for a while?
No, I think it's permanent. I think what happens, and especially for sleep patients, is that the ring is going to stay in the abdomen. So the scar around the ring is going to maintain the sleep inside the abdomen. I think that's probably one of the main mechanisms of preventing reflux of the Linx in sleep patients. However, we need more data on the sleep patients because I think that the results in sleep patients are not going to be as good as the patients in non-bariatric patients. However, we have to face that reflux after sleep is a big issue and is becoming more and more complex. The problem of Nissen sleep is that who are we going to do Nissen sleep to? Which patients are the ones that we're going to predict? Because many times we don't know which are the patients that are going to develop reflux. And I think that we shouldn't do end sleep to all of the patients.
I agree with that. But for example, the patient with a Crohn's disease, obesity, and reflux, what option we do have? Obesity, Crohn's disease, and reflux.
There are few patients.
Of course, I know, but
yeah.
But you have that patient in your office. What do you offer for that?
If you had obesity, I would do a bypass probably.
With Crohn's disease?
Yeah. If you had a lot of reflux, yeah.
Andres?
It's a very tough question. Of course, we have to offer something that works, that doesn't compromise the patient in the future, especially in regarding complications of his comorbidities. And Crohn's disease is a big issue because, as you all know, it's a disease that starts at the mouth and goes all the way down through the alimentary tract. So being conservative with these patients is an option, and the least aggressive operation perhaps would be my choice. It's not an easy answer to. I would try to do a sleeve, a Nissen sleeve. I really don't like Nissen sleeve. I strongly believe that we are getting the worst part of both procedures, but in some selected patients, as you are describing, perhaps can be an option. On the other hand, and talking about again about the Linx, how many patients do you feel that will be revised, operated again because of complications with the device?
Surgery after?
Yeah.
I think it's going to be very few. We've done a couple now, And we thought that the revisions would be in a nightmare, very difficult, and it's very easy because there's a scar around, so it's very safe around the esophagus. And now with the new devices, probably the erosion is going to be very, very low.
And just until we get the next one, I just want to comment that sometimes it's okay to say we're not going to operate. And it's okay if I believe if someone with very severe reflux and wants a sleeve, instead of doing end sleeve, for those who don't do end sleeve, like my practice, it's okay to say we're not going to do it. LA grade D esophagitis, does not want to bypass. I tell that person, I'm not going to operate on you. We have to remember that we don't have to operate on every single person. And ultimately, we are the doctors, we are the surgeons. It is eventually our choice to do. That's just an opinion. Gracias.
We are ready for the next debate. It's going to be between one new device versus talk is Patrick Noel, and he's going to talk about Bariclip here to stay. And the second one is Bariclip will be next gastric band. Will be next gastric band. That will by Dr. Marco.
Good morning, everyone. It's a real pleasure to be here with you after these long years. So today we'll speak about a new technology, a new technique, the Bariclip, and I will debate with Marco on this device. So Bariclip is here to stay. I strongly think that. What is the Bariclip and how it's working? So it's a vertical device implanted parallel to the lesser curvature and made from titanium covered by silicone. It's a reversible procedure, a restrictive procedure. There is no adjustment like with a band. It will divide the stomach in two parts, an alimentary one and an exclude one. The exclude part, which is the advantage of this one, will allow to decrease the gastric pressure in the alimentary stomach, making the Bariclip a non-reflux maker. Bariclip is clipping, not cutting. It's not a new gastric band. It's vertical. It's a restrictive procedure. It's not oblique or horizontal like a band which was an obstructive procedure. The consequences are the absence of chronic dilation of the esophagus, and we see a very low rate of GERD. So possibly it's the alternative when you to another system for patients with reflux or with low reflux. So weight loss is superior with a Bariclip as short and midterm than with a band. Definitely no adjustment necessary. And quality of life, we studied that, was very good. So why the Bariclip is here to stay? Because we need something after the band. Band has so many weaknesses. Because we need something more efficient than endoscopic procedure, and probably this new technique is more sustainable. We need a new technique less invasive in surgery. Because we need something reversible, will be able to be a bridge for some patients. And because it will replicate the effect of the sleeve, which is, as you know, the leader in bariatric procedure today, without this problem, this issue of reflux. No, we have learned from the story, from the history. All technique will fail It's just a question of time. Some will fail sooner than the others. The majority of our patients, we have to be honest, will have at least 2 procedures in their lifetime. And I really think that we have to start with a better compromise, and possibly Bariclip is one of these. All surgery have complications. As we know, we need less aggressive procedures with less serious complications. And even if it's a foreign body, is acting as a low pressure system, and it will give few erosions like the Linx, I think. Thank you very much.
Marcos. I have my presentation, please. Thank you very much. It's a pleasure to be here. Good morning, everyone. With my friends here in Miami and worldwide that are watching. Thank you, Nathan, Eduardo, and all friends here panel for the invitation. So I'm going to talk about Bariclip will be the next gastric band.
Oh, yeah.
Sabotage.
Huh? So go back one, please. Disclosure. I have a disclosure. And the reason is that I have already initial experience with the Bariclip, and my impression was not bad at all. However, if we go back 20 years ago, you remember this, remember the lap band. And when we start putting bands, it was described as it may have possible complications, but its advantages are many compared to other procedures. It is reversible, does not alter the normal GI function. Does it sound familiar now? Is this a real new technique, or is it the same principle as a band? So the Bariclip, as Patrick told us, is presented as a procedure with no stapling, no risk of leaks, low risk of bleeding and visual deficiencies. So it's presented as an alternative. However, is it effective? This is the first paper here from surgeons from Miami. There was pretty good results with the pilot study. They had complications as we expect, but the main concern at the first experience was the slippage or the displacement of the clip, up to 8% almost. Then we had some other papers from Dr. Noel that the erosion rate has come down to a very decent rate, about 1% or less. And also they found that with experience, the displacement or slippage is coming down to 3%. But we do know that with all foreign bodies, we're going to have this. We're going to have this slippage, displacement, erosion, GERD, all these problems. But we already have some papers that are describing removal of the clip because of complications. And this is our experience I want to share with you. 2 years ago, we placed 11 clips, BMI low, 35, and we had a pretty decent weight loss, as you can see there, up to 64% excess weight loss, 17.27% total weight loss. It's still less than the sleep. We had about 75% weight loss with the sleep, but the weight loss was very good. However, this is where our problems. We had some complications. We have one case that we have to remove after 6 months because of poor quality of life. He was having some gastric outlet obstruction. He didn't have a complete obstruction, but he asked for removal. And we had one acute slippage. After 5 days of surgery, we had to reoperate and reposition. So our reoperation rate is pretty high. It's an early experience. We have 18% reoperation rate. But my main concern was this. When we look at these patients after 2 years, look at the weight loss. This is one patient, started with 95, came down to 84, and almost the same weight after 2 years. This second patient, the same. These are the same patients treated by the same team as sleeves or gastric bypass and the same medical follow-up. So we are having poor responders. Why? We don't know clearly right now. So in conclusion, although this technique is comparable to other techniques, we have a very high rate of reoperation and weight regain. So my main concern is the durability long term. It's gonna last. We do know about intraforeign bodies, intra-abdominal foreign bodies with problems with the wrist, slippage, migration, obstruction, erosion. And you know what happened with the lap band? We had 10 years putting bands, then after 5 years are taking out the bands, and nowadays nobody's putting any band anywhere. So I will not repeat the story. That's the answer we have to do ourselves. Bariclips try to emulate sleep, but we don't have any study whatsoever about ghrelin or other GI hormones. We already have the sleep, we already have a Roux-en-Y. They're not perfect, but they're pretty good. Why we need another new technique? I think that the Bariclip is not ready for mainstream or for prime time. Thank you very much.
Do you want to answer to his talk?
Yeah. You're paying something. I can agree with you on one thing. We need more data, first thing, because you can give some conclusions on, I think, on 11 patients. This is not a strong data. So we need more data. We are collecting now international data. We did almost 400 patients worldwide, 500 patients worldwide. And now the rate, as I told you, of slippage was an issue at the beginning with 7.7%, dropped first at 3%, and now on the last 200 patients is less 1%. Regarding the erosion rate, we need more data as well, we need more time. But now globally on 400 patients that got an endoscopy after the surgery, we have less 0.5% of erosion, migration. So the concern, but I don't think we'll so many migration like with other device as the Linx. So more data for sure. For some patient, I really think that we need to choose a good patient for the good surgeries, like with sleeve, like with band, like before with gastric band. And obviously, we have not to give this procedure to everyone. I think a low BMI prepared with a multidisciplinary team with a technique which changed a little bit with time. Now the fixation of the Bariclip is different. Probably the reason we see less and less complication. We are adding now a technique of plication of the antrum, and with that, the result we have now for months, almost 1 year, are getting very close the one of the sleeve.
One comment.
Thank you, Dr. Romelanzuk, and thank you for both of talks. The problem is that we have to choose which is the patient that you are going to apply this dispositive, because it's very difficult to fix many problems. One problem is the place. One problem is the surgeon who performed the procedure, but there are another things to fix, like what happened with the patient who needs some restriction, but he don't want to be cut at his own stomach. Yeah. And that is, for me, the most important indication for this patient, but we have to make the consent for this procedure, because has many possibilities of slide of erosion, and for not work in waiting in losing weight for at all, like Dr. Barry has shown in his talk. So for me, we need to have more follow-up data, because with data in 1 or 2 years is not enough. I think that we need 5 years almost, and maybe we are going to see the real situation of the Bariclip. The idea is nice idea, is not cutting your stomach, works theoretically with no problem, but what about the other problems? No, erosion, node function in losing weight, and what happened with the problems in the technical implant. That is.
Patrick, have you had an experience with conversion after the clip with poor weight loss?
So I convert two Bariclip, not for weight loss issue, just because this patient, I did the surgery in Dubai, moved to Saudi Arabia, and no surgeon was able possibly to follow them. But because at the opposite, they lost a lot of weight, I spoke with the family and we decided to remove both of the Bariclip, and they wanted something else. And doing the same procedure, I converted them to a gastric sleeve without problem.
Before finishing, I have a question because I have also been involved in the Bariclip. I have seen the patients with reflux, they don't have that much reflux after the procedure.
Yeah.
That's an interesting concept.
Yeah, this is, I think, one of the most interesting reasons to think about Bariclip. You have, as you saw, an exclude part of the stomach. And when we did some barium swallow, some radio study, we saw a reflux going in the exclude part of the stomach and no reflux through the stomach, through the esophagus. Probably it's becoming a low pressure system with an exclude part. Will make a balance for the high pressure, for the pressure inside the stomach. And definitely we are collecting data now. We have very, very few cases of reflux de novo. I think around 1%.
Thank you. We're going to move on to the next fast debate and the last one of this first block. We are going to ask Dr. Jaime Ponce and Dr. Enrique Arias to come here. We are going to speak about sleep failure. Dr. Jaime Ponce is going to talk about after sleep failure, Roux-en-Y gastric bypass, and Dr. Enrique Arias, SADI-S. You can begin.
So thank you very much. Thank you, Nathan, and congratulations for putting this meeting together today. So my position is going to defend that Roux-en-Y gastric bypass is a better option than SADI after a failed sleeve gastrectomy. You have the...
I don't have.
The remote.
So the question here is Roux-en-Y versus SADI. So it's very nice picture when you convert the sleeve to a bypass. Very nice picture when you convert the sleeve to a SADI. Now the problem with this picture, the second one converted to SADI, is that you need to have, in order to convert it to a SADI, you need to preserve that sleeve pouch. So that sleeve pouch has to be very nice, has to be in perfect condition in order for you to be able to do a SADI. So I would assume that my opponent is not going to argue with me that converting to a SADI on this situation is not indicated. So if you have a sleeve damaged with stenosis, kinks, or any complications, you probably are going to prefer to do a Roux-en-Y gastric bypass instead of leaving that pouch there for a SADI. Even in these cases in which you have reflux, my opponent is probably still going to agree with me, I would assume so, that in cases of reflux, he's not going to leave that pouch and continue to have more reflux and more complications. So I guess on these cases, we're not going to have a lot of argument in regards to complications from the sleeve pouch, and in those cases, you probably are going to agree with me. Now, you probably are going to show me data that in regards to weight loss, you're going to have a little stronger proposition. Well, there's a couple of meta-analyses that I wanted to just summarize for you. You probably are you've seen this, but this is a meta-analysis of all the conversions from Roux-en-Y gastric bypass to a sleeve gastrectomy, published just July this year. And so it's pretty recent, 17 studies, 550 patients, very typical patients. Now, 1/3 of the patients are converted for reflux. Again, those cases, you probably are not going to argue with me because the Roux-en-Y gastric bypass is a better option than the SADI. But 50% of those patients are converted for poor weight loss or weight regain. Those are the ones that we're going to be arguing. And you probably are not going to argue with all the complications that are also converted to Roux-en-Y gastric bypass, which is stenosis, torsion, or other mechanical complications. In regards to comorbidity resolutions, I can show you that the Roux-en-Y gastric bypass is very effective to resolve the reflux, to improve the type 2 diabetes, and this is according to this meta-analysis. And in regards to weight loss outcomes, you know, it's pretty decent, obtaining 40% at 12 months. This is it's available in the literature. Now, they also talk in this meta-analysis about the weight loss that you may get with BPD and DS. Notice that I say BPD and DS and not SADI because that's what this meta-analysis shows. So don't come and tell me that that's the same weight loss that you're going to get with SADI unless you have something to prove it with. But the other problem is that every time that you convert it to a DS in this paper, it shows that you have higher incidence of complications. So now it becomes an issue about risk and benefits. You know, you're gonna try to get some better outcomes at the expense of more risks and more reoperations and more problems. Now, there is a meta-analysis that hopefully you review that it was published comparing the Roux-en-Y with SADI to as a second stage to resolve a sleeve gastrectomy problems. In this meta-analysis, the problem is that it's only including 6 retrospective cohort studies. And out of those 6 studies, only 2 studies talk about SADI versus bypass. The other 4 studies talk about BPD-DS. But even if you include the 6 studies, weight loss favors the BPD-DS group. But when you look at only those 2 papers, which I extracted from the meta-analysis, one paper, the weight loss is pretty similar, extremely similar. So really, the conclusion of this meta-analysis is that there is very insufficient data. You don't have very good data to express or to define that there is a big difference in regards to the weight loss. So to me, hopefully you want to argue with me that converting a sleeve gastrectomy for anatomic problems or reflux goes to a Roux-en-Y. Even when you have poor weight loss with reflux, you're probably still going to go to Roux-en-Y. And the question is, when there is no reflux and no weight loss, you have to still look at risk and balance. So still some patients may not necessarily need to go to more risk for the benefit that they're going to get. Thank you.
Thank you. Ricky.
Good morning, everyone. Could you please play my slide, please? Thank you. I would like to thank the organizer first for inviting me to present today. Second, for giving me the better procedure to uphold. SADI-S is a better option for patients with a sleeve gastrectomy after weight regain, and I will explain today why this is. But also I have a public complaint for them because they changed my opponent last minute. They choose one of the most famous bariatric surgeons, and also they changed the topic because it's supposed to be one anastomosis gastric bypass, and they changed for Roux-en-Y gastric bypass. But that means that SADI-S by itself is stronger, and it doesn't need my explanation to be the winner of this debate. First,
not my fault.
First, what do we know about SADI-S? SADI-S was introduced in 2007 by Dr. Sanchez Pernaut, and was accepted as a modification of duodenal switch. And is a single anastomosis duodenal ileal bypass with similar weight loss and metabolic result with a lower complication rate. And also is named a single anastomosis loop duodenal switch, also stomach ileal pylorus preserving surgery, but it's the same procedure. This procedure preserves the pylorus and has many advantages for this reason, and also is a procedure that is adopted for many surgeons around the world, and maybe will be the bariatric gold standard procedure at the near future. But you can see here the SADI-S with the single anastomosis and 300 centimeters common limbs. And you can see here the excess of weight loss near 90% after 2 years. Also the metabolic effects, you can see here almost all the diabetic patients are not using any medication after 5 years. But what do we know? We know about SADI-S after sleeve gastrectomy. Here you can see a lot of papers explaining the result after convert a sleeve gastrectomy of to SADI-S, and you can conclude that SADI-S is offer a satisfactory weight loss and similar metabolic effects with lesser complication rates of duodenal switch. And what is the evidence? We have some papers explaining that. You can find, I hope Dr. Professor Ponce read this paper, and you can see here a multi-institutional revision. This is a paper that explains that SADI-S report excess of weight loss of 64 after 1 year and diabetic remission rate of 93%. The conclusion was the SADI-S is an effective weight loss option for a sleeve gastrectomy weight regain patient and has a less complication rate than duodenal switch. But what do we know about SADI-S versus Roux-en-Y gastric bypass? That is the topic of this debate. Here you have the data about the duodenal switch has 80% of weight loss and Roux-en-Y has 65%. And also comorbidity resolution is better for duodenal switch. I know that Dr. Ponce will explain you that this is duodenal switch, not SADI-S, but you have many papers explain you that duodenal switch and SADI-S has similar weight loss and metabolic effects, but with lesser complication and a easier technique. Here is another paper. This is comparison of Roux-en-Y gastric bypass versus SADI-S, and also has SADI-S better results than Roux-en-Y gastric bypass, 88% of weight loss versus 78. And also with a patient above 55 of BMI, SADI-S was better. And then we have another papers of coming from China with patient above 35. This is a paper coming this year. It's only online publication, and these have better results for SADI-S than Roux-en-Y gastric bypass. This is the evidence. You can find a lot of evidence telling that, but this is our experience with SADI-S. We convert 22 patients from sleeve gastrectomy to SADI-S, and we have 80% of excess weight loss and 87% of comorbidity resolution. And I only have I explain you a variety that we have to super for convince that SADI-S is a good procedure. Now, the first one is the technique that I think that is the most important point because surgeons don't want to perform SADI-S around the world.
Thank you, Enrique. I'm going to give you 1 minute each other, please.
Yeah, I mean, it's interesting that you, of course, you didn't address the fact that for reflux and for sleeve pouch problems, you probably are going to support the Roux-en-Y gastric bypass. So I guess you agree with me on that part. Second thing is, you didn't mention anything about the risk of the SADI procedure. You also show us the benefits and the potential benefits on comorbidities, which actually, when you compare those numbers, you're talking about 10-20% difference some of the comorbidities, but you don't talk about the risk, which is also a 10 to 20% difference in complications.
Yes, first, well, if you are talking about the complication after sleep, I am agree with you that you have to convert for reflux. Reflux is a complication after sleep. Then I am agree with you that gastric bypass, Roux-en-Y is a better option. But if I am talking about the weight regain, SADI-S is a better option. Now you are talking about the technical implication of SADI-S, and I think that if you are able to perform a Roux-en-Y gastric bypass, you will be able to perform a SADI-S. It's a technique that you only have to improve the duodenal dissection and be carefully with take the size of the common channel because you have to use a marker grasper or a ruler, because if you do the same way to perform this size at the same weight of Roux-en-Y gastric bypass, you can have a shorter channel, shorter common channel, and you will be in trouble. Thank you.
I have a concern about SADI-S. What about the duodeno-ileal anastomosis? I think is has more risk than the other one. Why?
If you review the literature, it's not true, because it has the same complication rate of Roux-en-Y gastric bypass. If you are able to perform a Roux-en-Y gastric bypass, you can do a duodenal ileal anastomosis. It's not difference. The only difference is the dissection of the duodenum. You be careful, but if you take the ability to do that, you can do the SADI-S, and SADI-S has better results in weight loss for patients with a sleeve gastrectomy weight regain.
And remember, it's not only about technical complications, it's also about the nutritional deficiencies that you can have over time.
What about the metabolic effects of?
But you don't have the same malnutritional effects with SADI-S than with duodenal switch. We have papers showing that the SADI-S is a better procedure. This is the reason because somebody changed the 200 centimeters to 300 centimeters SADI-S. I agree with you that if you perform the SADI-S with 200 centimeters, you will have malnutritional effects. And this is the reason because in Latin America, somebody avoid to perform SADI-S because they count the from the ilion cecal valve, and they do the same weight of Roux-en-Y gastric bypass. And when you use a ruler, you see that the distance was shorter than they was expected. And this is the reason because we have malnutritional effects. If we use 300 centimeters, we don't have malnutritional effects.
I have two questions from the public. The physiological gut hormone changes are similar after sleeve and Roux-en-Y, so probably makes more sense to do a one anastomosis gastric bypass or SADI-S after sleeve rather than Roux-en-Y for poor weight loss. What do you think about that, Jaime?
So it's better to do a one anastomosis gastric
SADI-S instead of Roux-en-Y?
Because of why?
Because of the gut hormone changes.
I mean, you have. I don't know if there's anything in the literature or has proven that there is a big difference in the gut hormones changes in between the two procedures. You know, certainly you have more stronger metabolic effect when you do a duodenal switch. The data on SADI is still not very strong and validated. You know, they're all retrospective cohort studies. We need to do a randomized clinical trial. We also need to compare the SADI with the duodenal switch to understand the difference in between those two. I do think that the SADI has a lot of potential, and I agree with you, independent of the debate. You know, I think the SADI has a lot of potential, and it's a good procedure, and it potentially will solve a lot of the questions. But Roux-en-Y has many years and many randomized clinical trials to prove the effectiveness.
Totally agree. SADI-S has the advantage of preserving the pylorus and has physiological advantage of that.
Can I have a question?
I have a question very fast. If you, let's take aside the Roux-en-Y. If you have only malabsorptive or disabsorptive procedure, which one would you choose? You have one anastomosis, SADI-S, the DS, even they are asking Santoro, all those options. Which one will you do if we take aside the Roux-en-Y?
No, that's a good question, because I think I will start with something that is less invasive considering the data that we have. You know, I think the SADI, I would probably go with the SADI before I go with the duodenal switch.
Felipe, you have a question.
Hello. You're gonna do a Roux-en-Y after sleeve. Do you do the same BP limb length and elementary limb for reflux, for weight regain? I mean, gonna be different. What are the lengths that you're gonna?
Yeah, I mean, there's a lot of controversy. So if you really are trying to address reflux, you know, you probably need to have, you know, decent size in the Roux limb. But you do the Roux-en-Y gastric bypass like you would do with anybody else. You know, you wanted to implement more weight loss, and I think there's now data that if you leave a longer BP limb,
Not for weight loss, just for
reflux, just a decent size, you know.
For regain?
At least 75 centimeters, if not more. For weight regain, I will go with a longer BP limb.
Thank you. Thank you very much to both of you.
So this is gonna be the final remarks. Thank you very much to you all for listening, for being present here. It has been hard for us to try to arrange all of this, but we are done. So let's continue. 9:30, we almost end. Thank you very much. Next session. Listo. There is a break for 5 minutes. Thank you, Nathan.
Camilo.
Exacto.
Pero para jugar el Linx, pero siempre
are Dr. Sylvia Wiener, who's a bariatric program director in the Department of Obesity and Metabolic Surgery at Krankenhaus Nordwest Frankfurt, Main in Germany. And then as well, we have Dr. Aparna Govil-Bhaskar, who is a consultant bariatric and laparoscopic surgeon in Saifi Hospital in Mumbai, India. And then Dr. Michelle Marquez, consultant bariatric gastrointestinal and laparoscopic surgeon, also a gastrointestinal endoscopist at ISSPE in Mexico City. And then we have some wonderful speakers. And we have Dr. Wendy Brown. She's a professor and chief of surgery at Monash University at Alfred Health in Melbourne, Australia. And she's also the current chair of the Ifso Global Registry Committee. We have Dr. Megan Jenkins, who's a bariatric and MIS surgeon, clinical assistant professor of surgery at NYU Langone Health. We also have Diana or Gabby Maldonado Pintado. She's going to give a discussion as well. She's a consultant bariatric and gastrointestinal and robotic surgeon at Ángeles Pedregal Hospital in Mexico City. In Mexico, she's also the Young Ifso LAC coordinator, chief of surgery of the Medical Society at Ángeles Pedregal Hospital. We have Luciana El Cadre, who's a metabolic and MIS surgeon at the Center for Obesity, Diabetes, and Metabolic Health at Gavea Metabolic Center for Obesity and Diabetes in Rio de Janeiro. And lastly, Dr. Aurora Pryor, professor of surgery, vice chair for clinical affairs. She is a former SAGES president, chief of bariatric foregut and advanced gastrointestinal surgery division, director of the Bariatric and Metabolic Weight Loss Center at Stony Brook, and also director of their minimally invasive and bariatric surgery fellowship. So it's my pleasure to introduce the first discussion, which is from Dr. Gabby Maldonado Pintado, and that session, that talk will now, thank you.
Hello, I am Dr. Maldonado from Mexico City, and the topic I am going to talk is about how to maximize your fellowship into practice. I would like to thank Marina, Nathan, and Ifso for this kind invitation to participate in such a great virtual meeting. When you are in training in general surgery, you are wondering what to do next, and we usually have many options. And one option is to go into a career with bariatric surgery. How do you choose where to do your training, and what are the characteristics that you need to consider it? Well, in 2010, there were in my country no formal training centers, and we started the very first one in our hospital, and that began my journey into bariatric surgery. We performed a complete university program of 1 year, supported by La Salles University at Ángeles Pedregal Hospital, and the title of the course is until nowadays Bariatric and Advanced Gastrointestinal Surgery Postgraduate Course, well known in many countries as fellowship. A correct training center selection is the first important decision in the future of your career, in bariatric surgery and also in general surgery. You are really starting and not finishing your training in surgery. But what are the characteristics of this year or of fellowship to choose first? Well, first you have to choose a center with adequate training and equipment. We choose our hospital where I am working now and where I did my residency and fellowship. You should choose a hospital with the correct certified equipment where you can offer to the patient security and good technologies needed for this type of surgery. After you complete your fellowship, it's wise to go and see other centers in a private university and public settings so you can finish your training with a broad view of what bariatric surgery is about. In my case, also, I had the chance to work a few weeks in a bariatric center, performing medical theories, and several years working specifically in bariatric programs, which offers you new knowledge, of course, and experience. And then you can get a big perspective about different ways to treat obesity in different centers and learn about everything. These jobs allows you to increase your learning curve and to participate in several academic activities. In my country, after about 11 years, actually there are several centers that are certified by the Mexican Board of General Surgery and the CMCOM, which is the Mexican College of Metabolic and Obesity Disease, where you can also have your training fulfilled, and we are working in the standardization and unification of all these programs, and probably in the future they will become in a formal specialty, obtaining an official number of certification. But probably they are not still enough, and many of them were stopped because of the pandemic and also by the new government resources available nowadays. Now, what happens and what's the evolution in bariatric surgery? First, you have to look, observe what bariatric surgery is about. Then you have to join into a training program, a certified training program, and then you have to fulfill your learning curve. Then it's important for you to become a professor and then a mentor, where you can teach the new generations the skills needed to perform surgery in a safe way. When you join into a fellowship, what are the important things? Well, certainly the number of cases you have to choose to be in a program where you have enough number of bariatric surgeries so you can have enough experience. Once you choose the program and the hospital, this has to be evaluated by different bodies so you can be adequately certified. In our center, we use several models for teaching. This could be virtual models, animal models, and also cadaver models as well. In patient surgery, also it's important with a big number of patients for this training and to accomplish these goals. It's said that you need about 125 surgeries per year, working in equipment in a team with experience in bariatric pre and post-surgical management. And very important, you have to follow your patients personal and institutionally, as well as your complications, so you can be adequately certified. Therefore, the learning curve varies depending on your skills and usually takes around 75 to 100 procedures for optimal results. And it's recommended you have to take some program with laparoscopic skills during your training. If you can do it before your fellowship, it would be an ideal. Either you are proctored or you are a proctor, you should be in the right center with the right equipment and with the right persons. What to expect with your surgery and explain them, you will be with them all along, all the time. I usually recommend also to our fellows to watch their own videos so they can learn by their own mistakes, using the camera, and also while they are using different instruments, as the same way the dancers, for example, learn about their movements in front of a mirror. Also, it's very important to communicate with other centers, national and internationally. Before the pandemic and the Zoom, there were efforts to do communication, and they were very successful. Believe it or not, this virtual conference was done by the first time in 2016, about 5 years ago, by Skype. Now, we talked about the characteristics of the medical center. Now, what's the individual characteristics? Well, first, you have to have the right attitude, of course. Then you have to self-evaluate your performance, your results, and certainly you have to be available during your fellowship or after your work, so you can become into a trusted surgeon. The knowledge you will receive in your fellowship goes along with your ability, with the skills that you will get, with the experience that you should obtain in the program, and everything goes back to the right attitude. and see then who you are, what you want, where are you going to practice, and what you want for your patients. There are a number of publications and presentations like this one of Professor Barry Jackson that told us what are the personal characteristics of the individual surgeon to become an excellent surgeon. You can see here some of them, to take good decisions, to have very good operative technique, to be humility, courage, to have a team working, have knowledge, adapt to a new learning communication skills with patients and their relatives, to be honest, leadership, and do unto others as you would have done unto yourself. There are also a number of institutions all over the world that it's important to communicate with surgeons and your institution to share knowledge, test yourself to see in reality how you are doing. You have also to register your patients and follow up them and report what your results are. You need to put your good results, your bad results, your complications, and to be very honest with that. In our case, we usually record all our data electronically, so you can share this data to other surgeons and other institutions. Also, there are several bodies who have recommended what is needed for the credential for bariatric surgeons. And finally, we should get all these characteristics to be successful, but of course, each one of us can choose what really we want in life. So, in conclusion, for the new formally bariatric surgeons, the recommendations are: you have to work in adequate hospitals and centers with everything you and your patients need. You have to follow proctoring protocols. Usually the teachers and the proctors, they must be certified bariatric surgeons. The patient selection is very important, especially at the beginning of your career, because you have to be self-conscious about what you need for further learning. You have to work with multidisciplinary team in your hospital so you can have the best results as you can, and then you can have an excellent and successful life. If you need some advice or if I can help in something, don't doubt in contact me. I would be very happy to help. Thank you very much and enjoy this virtual event. Thank you.
Our next speaker is going to be Dr. Luciana El Cadre from Brazil, and she's going to be discussing what to expect with one's first job.
Hello, thank you Ifso, Marina and Nathan for having me here. I have to confess that I found it difficult to prepare this talk, considering that when I started in surgery, everything was different. No internet, no social media, no WhatsApp groups. So I will try to collaborate with what seems to me immutable. To start from the beginning, almost half of us change the initial journey or simply leave it. 40% of women physicians go part-time or leave medicine altogether within 6 years of completing their residencies. Our training starts in the mid-20s and continues in early 30s, the prime childbearing years. And transitioning from maternity can be even more difficult. A recent paper estimates that at the current pace of change, it could take nearly 120 years to achieve gender parity in surgery. On the other hand, by 2032, USA will lack as many as 23,000 surgeons. Unemployment is virtually non-existent among male surgeons, but many female surgeons, as well as professional women in other fields, experience underemployment and underuse of skills. And this is not changing, suggesting that the bias toward women is systemic. And then the current method in place for helping female surgeons advance professionally isn't working. So the first thing is to don't be afraid of not doing it right the first time. Because 50% of fellows will change jobs within 2 years after finishing training. But to change, you have to be psychologically and technically prepared. And you can't have an hermetic training. So it's really possible that you have to change at 10 years after the starting of your practicing. So what to expect? You will work hard and some people won't like you. And what to do? Understand that everything changes when you are not longer a resident. Remember your value. Don't fall into a bad stereotype, like wanting to be the man of the group. Surround yourself with people that are better than you, and have someone to learn from and someone to teach to. So resilience is the ineffable quality that allows some people to be knocked down by life and come back stronger. So be resilient, but face competition head on. And understand who you are. Understanding your professional strengths and weaknesses is key. Your responsibilities as a surgeon depend a lot on the type of practice you choose. Remember that timing matters. So really sit down and think about what your priorities are and what you can let go of. So get started 2 years before the residency is complete. Organize and draft CV. Prioritize and outline your goals. Acquire key documents. Prepare paperwork. And sit for phone interviews. So what challenges are you likely to face looking for a job? Many challenges. So have a professional online profile. Remember that it's not only what you know, it's who you know. Use a job post and website like LinkedIn. Get to know the type of people you are competing with. And remember that knowledge equals power. This isn't a joke, but it's really interesting. It appears that no performer achieves elite status without investing years of deliberate practice, have ongoing coaching, and using repeated physical and mental rehearsal and warm-up. Except maybe surgeons. So we spend many years in residency and then we are declared competent and independent. So we all have fear because the thing that we fear most is change. So it's nice to have someone who is evidence-based and can cite research, and also someone that is more responsive and can think quickly. So if you are starting out, it helps to have an established network that you can call with questions and for advice. Try to find a trusted mentor and try not to work alone since the beginning. Connections are key, so do as much research as you possibly can. Talk to as many people as you can and have or know someone that can vouch for you. Never hesitate to negotiate. What are your values? Identify what is most important to your lifestyle, such as income, faith, the ability to go on vacation or meeting new people. Don't take the first offer. Decisions made after residency can greatly impact your career. And it is important to not jump at the first opportunity that arises. It's really interesting that the future physician shortages are a strong indicator that physicians should be negotiating from a position of strength. But many residents entering the job market may not be aware of how that translates to compensation. Most successful surgeons express a level of confidence, and you all know. in their abilities that often exceeds that of many other physicians. Such observations have led to the joke that surgeons are often wrong but never in doubt. So teaching the next generation of surgeons to recognize the tension between confidence and humility is worthwhile. Achieving the right balance is a lifelong pursuit, so ask for help when you need it. While you are eager to prove your abilities, showing humility in the workplace can be more important initially. No matter how many minutes you have left, take care of your body and your mental health. So hard work, time pressure, stress, and a demanding schedule have less of a toxic effect than a lack of mindful engagement with life and those with whom you share it. If possible, involve and not exclude your family from your career. Be an active listener to your patients and adapt to change. What we know now as patient care delivery will definitely be different in 20 years. And how I practice, as I told you, 20 years ago is barely recognized now. So change will occur even more quickly over the next several years. So be prepared to change. So lights on now. 10,000 hours of, or 10 years of deliberate practice are required to achieve expert performance. In this case, we are talking about a violinist. So surgery is a career of lifelong learning. Never stop learning, never stop reading. Keep reading, because the trouble in life is not what you don't know, it's what you don't know you don't know. Team job. Be a good colleague, have good colleagues, and try to exert leadership. Really, really important in surgery is to understand that surgical treatment is not only a question of death and life. It's also about quality of life, your quality of life and the patient's quality of life. Surgery is not only about operating. And to finish, finding the right work is like discovering your own soul in the world. And control your own destiny, or somebody else will do it. Once again, thank you very much, and I hope to see you all very soon.
Thank you, Luciana. We look forward to the discussion. The next topic is going from assistant to full professor. What are the pitfalls? And this will be by Dr. Aurora Pryor.
I'd like to thank the Ifso organizing committee for the opportunity to speak today. My topic is from assistant to professor. What are the pitfalls? Otherwise known as how to get promoted. These are my disclosures, none of which are particularly relevant for this talk. What is relevant are these are my positions. I'm a fellowship program director. I'm a division chief. I'm the vice chair for clinical affairs. And in all of these roles, I spend time helping people get promoted. I'm also a professor with tenure, which means that I personally have at least been successful with this myself. So what does it take to get promoted? Some of the key things, I think, ask for local expectations, because your institution may be different than mine, but it's different from somebody else's. So it's really, really important to find out what your local rules and regulations are. Often you can find the promotion and tenure committee guidelines published on your website or maybe in a paper format. And often these are given out early in your academic career. You can also set your expectations with your boss. And I think this is probably the most important way to get started. Figure out what they are looking for you to do. Try to align those things with things that are important for promotion and tenure, and really try to be goal-directed in what you do and how you spend your time. So let's talk about some of the key things that are involved. And first and foremost is be a good partner. Make sure you're helping others at your institution. Make sure that you're standing up and you're the kind of person that they want to continue on the faculty. Some of the things that I personally look for, people that are self-motivated. We want you to have good outcomes in clinical care. I think those are pretty much the basic tenets for any faculty. You want to agree things that you can complete without prodding, but also don't be afraid to ask for help. Collaborations and follow through on those commitments is really essential. Be available to your patients and partners, and be affable to all. It's helpful if you can be easy to work with, and be proactive when problems arise. So it doesn't mean everything's going to be perfect, but try to be somebody who comes with solutions more often than problems. Other things that I expect from my colleagues: professionalism when it comes to call, billing, documentation, and collegiality, engagement with the team and participation. Being open to constructive feedback makes things easier on me as an employer. Looking for professional behavior and demeanor, and people who understand that they're part of a team and support their teammates are all things that make it much easier for me to promote my colleagues. So some of the core things that are going to be on your CV that are expectations at most institutions for promotion include teaching. And this can be presented in a variety of different ways, from lectures or presentations, either internal, external, or in a variety of different formats. You could be a moderator, a course director, you can teach in a simulation lab, or this can also include clinical teaching. These things are often hard to remember that you've done, so it's really, really helpful to keep these things in what's called the dossier. So keep a record electronically on your CV, or in some way, shape, or form, even in a file cabinet, so that you can look these things up when it's time, because often you'll be asked to itemize your teaching responsibilities and obligations when it's time to get promoted. Other things that may or may not be important are clinical productivity, definitely clinical outcomes and clinical reputation, but you can document a lot of these things by case volume, RVUs, success on your profit and loss statement, could be collections or clinical volume, how efficient you are in the use of your volume and time, outcomes, and also costs for your care. Again, these are things that you can try to document, and keeping a record will make it more helpful for the future. Some of the other things that are important for clinical productivity is if you're a clinical innovator, you can write these things down. If you have thank yous from your patients, those can be things that are included. If you get local or regional awards, those are also things that can be helpful to say that you've been successful and are really doing a good job clinically. Abstracts are sort of the easiest tier of academic success, and you can keep track of abstracts that have been submitted, accepted, published, and presented, and what kind of format was that done in? Was it in person? Was it oral versus poster? And what was your authorship role? For the most part, things that were first author or senior author are given the most credit, and middle author presentations and publications are often less valuable. Papers definitely have importance, and this can be in a variety of things also. These should be kept track on your CV if they're presented, submitted, accepted, and published. Some people ask for the impact factor of the journal, and this is something you can actually look up online. It's essentially a pretty straightforward formula that talks about the number of pages in the journal, how many times something has been referenced, and it can be your personal impact factor. Each journal has one as well. There's also some newer metrics to look at the strength of the things that you're being published. There's some Google metrics that have been helpful, or other things that H-index, for instance, probably beyond the scope of this presentation, but the more well-known or highly cited things are, the more impactful you are. Authorship role is also important in publications. Again, first author, senior author, the most important. And these things can add up in terms of number of publications, quality of publications, and also to help solidify your reputation. Books and chapters are probably less valuable on your CV, but they are filler. They show that you're doing something. They're acknowledgement of something that you're doing well enough clinically to get asked to do it. And it also helps get your name out there. So these are a valuable tool to incorporate as well. Institutional service also has some importance with committees, call coverage, internal accomplishments and awards, and even accolades that can be helpful for the group as well as you as an individual. Local, national, and international reputation can carry on in a variety of ways, from society roles and vital talks and collaborations. The other thing that I think really helps build your local and national reputation is if you're doing grants or getting research publications and really bringing in that money and revenue from what you're doing from an academic productivity standpoint. And these are things that look good for your supervisors as well as good for your institution. So there are a variety of places that you can misstep in trying to get to the next level in promotion. Number one is getting caught up in things that are not value add. If it's not something that's looked at by your promotion and tenure committee, think hard before you agree to it. Some of these may be extra teaching roles, some of these may be things where you're helping out, and they may be things that are completely valuable to you, but look at it hard, because there's way too many things that we can do in our day compared to the hours that are available. I think it's also important that if you know your criteria and you know you qualify, sit down and ask for promotion. This is something that sometimes we, particularly as women, don't do a good job for. So making sure that you are aware and you ask for that promotion, and don't forget to ask again. And it's not just academic promotion, it's actually getting a raise. If you don't ask, it's not going to happen. The other thing that I think is important is knowing who and when to ask for help. If you're struggling with publications, if you need help with a grant submission, these are the things that reaching out and asking is going to really make the difference and help move things along. I think if you follow these steps, hopefully you'll be able to be successful and climb the academic ladder. I am happy to help you if you need some guidance along the way, but I'm sure there are a lot of others in this session and in Ifso in general who'd be happy to help. Thanks again for the opportunity and the ability to present today. Again, I thank the organizers. Have a great day.
Our next speaker is going to be Dr. Megan Jenkins, who's presenting about the current situation of is publishing a paper more important than your social media presence? What should we be spending our time on?
Good morning, afternoon, or evening, everyone, depending on where you are in the world. I'm Dr. Megan Jenkins from NYU in New York City. Thank you so much to Ifso and the whole panel for making this happen. We've had a lot of awesome topics, and I'm really excited to discuss this pretty interesting and pertinent topic nowadays, the future, publishing papers or posting. I have no relevant disclosures. As you guys look at this slide, I think everyone probably remembers these medical journals that we worked our butts off in medical school and residency to publish in. And even, now we're still working hard to publish. When I Googled the best journals for physicians to publish in, I found some ones that you probably are familiar with. And they have some things in common. They have a couple 100,000 readers, and they're just as difficult to get into as an Ivy League school. But these days we live in a world of inclusivity and social media. Everybody here probably can recognize at least one, if not all, of these social media sites. And when looking at the top 15 social media sites, you can see it's much more inclusive. In 2008, there were basically minuscule numbers of people participating in social media. And now, in 2018, there's billions. In fact, on a monthly basis, 2.6 billion users are active on Facebook in comparison to the couple 100,000 on journals. When you look at the top 15 social networking sites, you see as more inclusive, You only need an email account to join Facebook. Facebook reached 1 million subscribers within 10 months. Furthermore, it's 500,000 new users per day, which is 6 new users per second. So it makes complete sense that about 70% of US businesses are actively using social media platforms for marketing, such as Instagram. So that begs the question, is the answer posting? What are journals actually for now in the 21st century? When you think about our evolution of our culture and you think about academic journals, they surprisingly have not really actually evolved that much since when they were invented 350 years ago. So why is it that research still remains such a pivotal part of academic medicine and furthering your career? You would think that, as our culture's changing and as, possibly, the younger generations are more interested in social media and posting, possibly the importance of publishing might go down. But in actuality, they did a survey of Australian doctors, and it was about 11,000 junior doctors or pre-registrars, which are basically, medical students or interns. And they compared them to registrars, which are basically residents and consultants who are attendings. And when they look at this, you see from 2008, when there are virtually no social media platforms or minimal people using them, to 2016, when now it's billions of people, there really isn't that much difference in the fact that the majority of people answered yes to the question, is publishing important for furthering my training and career? In fact, when you look at the highest percentage of people saying yes, it's actually the younger generations. It's these younger people who really strongly agree with the phrase, publishing is important to furthering my training or career. So maybe we won't ever get rid of this publish or perish mantra. It's really important in academic medicine for promotions to have publications. But that doesn't mean that we can't incorporate social media into our practice too. It is obviously very, very important nowadays. It really can help bring patients into our practice and to engage them more. In fact, 54% of physicians are already using social media. In fact, it's such a high number that the American Medical Association has supports social media, has put into place guidelines for stuff such as HIPAA and not sharing personal information, maintaining professional relationships online, etc. So when thinking about social media for physicians, there's an obvious benefit. You can connect with your colleagues internationally and around the world where you weren't able to do that before through collaborations on Facebook and YouTube videos. There's also professional and educational reference materials. There's journal clubs online. You can market. You can provide patient education through, classes on Facebook or webinars and stuff like that. You can engage your patients more. Obviously, there are some potential negatives you have to worry about. The possibility of sharing HIPAA, internet trolls, and sharing false information that can actually damage your reputation. So social media can actually really be used for professional development and patient engagement. Now, journals are actually starting to understand the benefit of social media. They realize that social media allows rapid dissemination of ideas and information. Breaking news is often seen on Twitter before it's actually even on TV news broadcasts. So medical journals have started using Twitter to disseminate important research or new and cutting edge research. Furthermore, reiterating some of the other points that we made earlier, social media allows networking between physicians with similar interests. There are a lot of groups on Facebook that allow physicians across the country, across the world to get ideas from other people about different patient situations or operative situations. Again, professional development through medical meetings online like this one, journal clubs, case-based discussions, and then again, engaging patients, because we know that a lot of people engage in social media. So that begs the question, if we can engage patients more on social media, might we be able to help improve outcomes even too? So looking at a prospective with some retrospective component survey, there were 686 participants. Half of them were experienced users and half of them were new users on a web-based social health network. It was forums of patients who were discussing diabetes, hypertension, depression, anxiety, etc. And what they found was that they looked at the frequency and people logged in and the duration in which they visited the site. And they found that there was actually a positive correlation between patients who logged on more frequently and stayed for longer periods of time with their activation, their relationships, and their knowledge of chronic disease. So I would be really remiss if I did not mention probably one of the biggest topics with social media, which is advertising. Obviously, medicine is becoming more and more of a consumer market. So advertising is becoming a huge part of our daily life. And, you know, it's obvious that with the number of people engaging in social media ad spending is doubling almost on an annual basis now. You can see here are some of our top places to invest. Makes sense. Some of the places that have most people, most active on a monthly basis. And you can see what small businesses can do with social media and advertising. Here on Facebook, a small business had 1 million in annual sales in just 2 years. According to a study, the average cost per click of Facebook ads was roughly 28 cents. And you can see, you can really engage people at a really high rate, 84% on Instagram alone. So in conclusion, I do not think the future is really choosing one or the other. I think it's going to be a balance of each. I think we need to continually progress through scientific research, which has been embraced in journals who have also started to embrace social media and start to make scientific research more available through Twitter, through open access journals. But we also need to embrace social media as physicians too. We need to use that to help develop collaborations and professional development. We need to use it to help engage patients. And then we also need to use it to help advertise for ourselves too. So I want to thank Ifso again so much for making a virtual conference available this year. I mean, even though we're not all in Miami, hopefully soon we will all be together again. So again, thank you so much. And I think we're going to take questions shortly.
Am I unmuted? Our next speaker is Dr. Aparna Govil-Bhaskar, and she's going to be talking about difficult people in your life and your surgical career.
Good morning, good afternoon, and good evening. It's really nice to see all of you here today. And at the outset, I would like to thank Ifso for this opportunity to speak at the X Factor session. My topic for today is managing difficult people and life in your surgical career. Someone said that the only certainties in life are death, taxes, and difficult people. Difficult people, I think, are something that we come across in every sphere of our life, and all of us have to deal with them. And according to the Global Human Capital Report, 85% of the co-workers have to deal with interpersonal conflict of some sort at work all the time. Difficult people come in various shapes and sizes, and in our hospital environment, we can have difficult senior colleagues. They could come as junior colleagues. We could have difficult hospital staff. And of course, we all have to deal with difficult patients. Of course, when we talk about difficult senior colleagues, the difficulties could be many kinds, and it could be about not being taken seriously. It could be about verbal abuse. It could be about not being given enough responsibility. It could be about not being given due credit for your work. It could be about not being given enough remuneration or about pay parity. It could be about not being given enough promotions. It could be about sexual harassment. It could be about departmental politics or conflicts. And when it comes to junior colleagues, it could be about insubordination. It could be about crude language. It could be about not doing duties properly and about being disrespectful. There could be similar issues with hospital staff. It has been seen that hospital staff tends to patronize male doctors more than female doctors. And of course, all of us have faced difficult patients from time to time. And again, I think female doctors tend to have um, uh, patients tend to intimidate female doctors more than male doctors at times. So what happens is that all these difficult people, which we have to deal with on a day-to-day basis, they tend to drain our energy, they decrease our productivity and happiness and increase our anxiety. And we tend to take all these stresses to our home and family environment, and our families, our partners, children, spouses. All these people tend to become the second victims of day-to-day stresses. And as women, we have greater difficulty in dealing with this because as women, we tend to prefer to foster a collaborative environment. We place higher value on relationships, and we are definitely more empathetic than our male counterparts. And sometimes when this happens again and again on a daily basis, it may feel like, there are too many locks and not enough keys. And you may feel very bogged down, and you actually end up feeling that every day you have one foot on the accelerator and on the other on the brake. So what do we do? I mean, how do we get out of this? Is it really possible to manage difficult people? Well, I don't think there is a set formula to this, or there is any a straightforward solution to managing difficult people. But yes, there are a few key concepts that I think as women who are practicing surgery or who are working in a male-dominated environment, we must keep in mind because we can't have a perfect solution to every problem, or we can't have a perfect way of dealing with every difficult person. But I think there are certain things which we must keep in mind. And one of the most important concepts is to be assertive. Assertion is an extremely important quality that I think every female surgeon or every woman must develop, and not only in a professional life, but also in personal life. And one of the aspects of assertion is that we must not be afraid of labels, because the moment you are assertive in your professional environment, you start getting labeled as being aggressive, or as being somebody who is, very overzealous, or somebody who is over enthusiastic. So I think that is something which we must not be scared of. Another thing is that we must not be afraid of saying no, because saying no comes a little hard for women. And we all know that if we don't learn how to say no, the only person who's going to suffer is us. The third thing is that women must not be afraid to ask for a seat at the table. That's the third aspect of being assertive. It is very important to ask for what is yours, because unless you are going to ask, you're not going to get it. I have trained many people. I have been a student myself. And that is one quality which I thought was lacking in myself, because I didn't know how to ask. And I saw my male colleagues and I see my male students. And just this morning, I was operating in the OR, and the male student promptly asked that, "Ma'am, can I put in the trocars?" And I was compelled to give him a hand. And the female student, the surgery student, she just came in sincerely, and she never asked. And of course, I did give her also, but that's because I know that she's not going to ask, and it's my duty to train her, but not everybody would think like that. The last thing is, of course, I think as women, we are very shy of taking due credit. I know of many, many women surgeons and many women, working women, who are very shy of taking due credit. They would do all the hard work, and especially when it comes to academics and probably research, They would do all the hard work, and at the end of the day, they may not even find their name when things are published. So I think it's important to ask for credit where it is due. The second concept, I think, which is very important, is that you can't keep everyone happy. You must learn to prioritize your relationships. You are the most important person, so learn to keep yourself happy first. Learn to be kind to yourself and practice some degree of detachment. If you find that somebody is being difficult again and again and again, and you have made your attempts at trying to bridge that relationship, but it's not working out, and I'm talking about professional relationships, I think it is important for you to place that person, take that person out from your inner circle and place them into the outer circle. And if it is still not working out, I think that person needs to go out of your circle completely, because if you don't do that, you will not be able to focus on constructive work, and your energy will unnecessarily get wasted into dealing with that difficult person at all times. So I think it is important to practice some degree of detachment. Next thing is, I think it's very important to pick your battles carefully. So when you are in a male-dominated environment or atmosphere, it is bound to happen that there will be certain irritants that will keep happening. So always introspect. Is it really worth it? I mean, save your energy for the bigger and more important battles. It's not necessary to react to every tweet, every social media message. Don't burn yourself out. Save yourself for the bigger and the more important battles. Now, I think this one is very important. Keep your power, because in case of disruptive behaviors where things need to be reported to concerned authorities, you will face situations in life, in your professional career, where things may get out of hand. It could be a colleague, it could be a subordinate, it could be a staff, it could be a patient, where some things are just not tolerable and they should not be tolerated. I think you must approach the concerned authorities, and you must go ahead and approach the right people and take it through the right channels, and you must not be scared. I think it is important to have a circle of support at that time, and people who can help you out and take the right advices, but you must not sit quietly and do nothing about such kind of disruptive behaviors. And these could be anything. Unfortunately, we don't have time to discuss about specific problems, but these things need to be addressed and they must be taken forward. The topic also includes a little bit about management of life. I think as women who are in a difficult profession, it is very important to have a circle of support. I know that we all have supportive families and extended families, but one thing which is very important to have in our lives is a sisterhood of friends. I have laid a lot of importance on this in, I mean, all my life, and I think all of you here also will vouch for this. That having friends is very, very important. Having friends who are there for you all the time, who just listen to you and don't judge you and don't give their opinions. They just listen to you quietly, and you can vent out whatever you want to say at that time. And you can just rely on them to be there for you at all times. These could be, I mean, they could be girls, they could be boys, whoever, but they're just there out to support you unconditionally. I think it's very, very important to have the circle of support in your life, and it really feels great, and you are lucky to have such friends. Next thing in life, I think is it's important to keep the humor intact. Don't take life too seriously. In medicine and in doctors and hospitals, of course, life is definitely very serious, because we're all dealing with life and death. We're dealing with surgeries, and we're dealing with a lot of pain. But have a little fun along the way. Whatever time you have, enjoy it, laugh, take it easy. Life is short. It's meant to be enjoyed. I think we spend a lot of time working hard, but have a little fun along the way. have a hobby and take care of your health. This is my favorite. You all know that I paint, and I cherish the fact that it's something which I do for myself. And everybody must have something that is just for yourself. It takes your mind off everything. It could be anything. It could be meditation. It could be a sport. It could be, I mean, just anything that you that's just your own, and you could do whatever you like. And also take care of your health, because health is wealth, and we realize its value only after losing it. So please don't lose your health. Take care of yourself. You're getting older every minute, and health must be treasured. So last but not the least, I think life is all about finding your ikigai. You need to find that one thing which you love, which the world needs, which you are great at, and which you also get paid for. I think for most of us, it is surgery. And for me, it is definitely surgery. So when I think about my life, I think I'm really happy to be a surgeon. It is, I feel very privileged to be a surgeon. And when I think about surgery, I feel that I've kind of accomplished my life's goal, and I accomplish it each and every day. I get up in the morning and I feel great about it. And whatever difficulties it brings along the way, I feel that yes, I can handle it, and with all the other problems that come along with it can be tackled, because we are all very passionate about what we do. And yes, of course, thank you to all the difficult people in my life and in our life, because they've really shown us that what we should not be. So thank you all very much. I hope I've not really overshot my time. Thank you very much, and have a great time ahead. Thank you to Ifso.
Our final speaker is Dr. Wendy Brown, coming in from Australia. She's going to show us how to find our bliss.
Many thanks for asking me to present in this very interesting session. I just wish it was in person. So I've been asked to talk about whether or not following your bliss means that you feel like you've never worked in a day in your life. These are my disclosures. I think the most important one is that this talk is based on my experience and my opinion, and I have no genuine expertise. So what do we mean by bliss? There's a lot of different ways we can define bliss, and they extend from the quite spiritual through to the very humanistic. As a healthcare professional, I think we often think about parts of our job that make it very, very satisfying. And for that can be things such as helping people transform their life or change their life, curing people, being part of a team, researching new ideas, innovating and inventing. These are all parts of our jobs that draw us to them and keep us working in the field. And the suggestion is that if you find your bliss and you follow your bliss, that you put yourself on a kind of a track that's been there all the while waiting for you. And the life you ought to be living is the one you are living, wherever you are. If you're following your bliss, you're enjoying that refreshment, that life within you all the time. And that's a quote from Joseph Campbell, who published extensively around the importance of finding life purpose. So how do you find your calling? Some people seem to be born knowing what they're meant to do. And in my experience from my friendship group, that's often my friends who are orthopedic surgeons. They seem to have been genetically primed, knowing that that's the right job from them right through high school, medical school, and during our junior doctor training, they've just had their eye focused on their target, and they've just kept going straight ahead and never deviating off course. But that's not the way it is for most of us. Most of us start out our path thinking we're going to do one thing, and then a series of doors open, and we open another door and we amble through. And when we look back, we think, gosh, how did I get here? So I started out my medical career thinking I'd be an obstetrician. I opened that door and found that I didn't really enjoy it. So then the next door that I opened was surgery, and that was kind of by mistake. But people really encouraged me. I really liked the teamwork. I loved the immediacy of helping people, fixing them, so to speak. I loved the opportunity to create. And so then I opened the next door and the next door. And then here I am sort of 20 years later, or nearly 30 years later, if I'm honest, and really loving being a surgeon. It was something I never planned, but you have to be brave enough to open those doors. So how do you know when you've found your bliss? Well, I think you have to think about you'll know that because you're really enjoying what you're doing every day, but you might find that you enjoy everything you do every day. So I think I would encourage you to think about the worst thing in a job, and if you'd be happy to do that every single day. So for this man who's a crocodile gamekeeper, the worst thing's probably cleaning the teeth of his large captee, I suppose. I don't know the right word for it, but he's the crocodile he's looking after. For me, I thought about colorectal surgeon, and I thought about Paredes ani. And I thought, could I see people who have itchy bottoms every day? And I thought, oh, I really don't want to do that. And then for upper GI surgery, which was my other choice, I guess the thing that I find hard is dysfunctional gut symptoms. And I didn't feel quite so despondent when I thought about that. So that's why I thought probably upper GI was for me. So if you find what you do, does that mean that you don't ever work another day in your life, that things become really, really easy? Well, I don't think that's quite right. You still have to work hard. You still have to train. You still have to put in the hours understanding and becoming an expert in the field that you've chosen. And on top of that, you're still going to have bad days, because we're never promised a rose garden. So if in the health professions, I think we have something that's really wonderful that we do. We are very blessed, and we are given the opportunity to lead someone through what is probably the darkest days of their life. But that makes our jobs very challenging. They're challenging mentally, they're challenging emotionally, they're challenging because of the environment we work in, where we have to constantly keep our cool, even under really difficult circumstances. We have to deal with colleagues that can be combative or can be somewhat competitive at times. And through no matter what's going on in the rest of our lives, our patients have to come first. So this image here is from the 1800s, and it depicts a doctor who's having a really tough day trying to save a little girl. And you can see on his face the worry and the concern. He's surrounded by the tools of his trade, which in those days wasn't very many. But his complete focus is on that little girl, hoping that he can come up with a solution. But he's not just managing the little girl, he's managing the family in the background who are terrified. And he's having to deal with, I guess, a whole thought that this is the nighttime and he's got a day ahead of him. So it's a tough job being a doctor. It's a tough job being a healthcare professional. And it means we will make sacrifices along the way. That can be to do with our family, it can be financially, it can be social lives, it can be missing out on holidays. And for us who are surgeons, there's the added complexity that we have to train really hard to become technically competent enough to be allowed to operate or to have the privilege of operating on another human being. So it's important to prepare for this. Don't think just because you found a job you love that you won't ever work hard again, because you'll work harder than you've ever worked in your life. And there's going to be days that are challenging. So have strategies for how you're going to manage this. Maintain friendships, maintain relationships, make sure you exercise, and follow healthy eating. Make sure you exercise. Because there's more to life than work. Follow healthy. So no matter how seductive and how wonderful your work is, because there's more to life, you'll love it more if you maintain. So no matter how seductive and how love your work, but find time to love life too. Because we should be working to live, not the reverse. You might wonder how you're going to fit all that in. And, often it's easy to look at people, particularly those ahead of you, and think, gosh, how do they keep their poise? How do they keep everything together? They're managing so many complex patients. They're doing so many difficult things. And yet they seem to be really cool. What you don't see is that they're just like you, that they're paddling really hard under the surface, trying to keep their head above water. So don't lose the faith. Just keep working hard. There's going to be times, even if you're doing what you love and what you're meant to do, that you really question your calling. You'll have complications in a row. You'll have challenging patients in a row. Just keep your eye on what it is you love to do. Remember that you're not alone, and keep working hard. So finding what you love is only half the story. You have to create the rest. You need to find a place where you can train, and then find a place where you can work that is right for you, that nurtures you, that has the kind of population, that attracts the kind of population you enjoy working with. You have to find the colleagues that will support you, that will challenge you, that will help you out when times are tough. You need to think about how you want to incorporate your bliss into your life. Do you just want to be a clinical surgeon? Do you want to work in public? Do you want to work in private? Or do you want to have an academic bow to your string? What's going to make that life that life calling more satisfying for you. You also need to maintain time to nurture that part of your soul that isn't nurtured by work. And that means having friends, families. It means having relationships. And whatever those relationships look like for you, you need to invest time in them. And also you need to have time to enjoy this wonderful big wide world we live in. And it's not just as simple as them all sort of intercalate, just tracking down and making your bliss easier. They all intercalate. And you need to manage this wide and wild web so that you can live the best life you can. But what do you do if you've made a mistake? What do you do if you think you've found your calling and you get down the track, and that can be sort of 10, 15 years down the track even, and you think, this isn't what I'm meant to be doing, I'm dreading going to work? Well, I'd really encourage you to have the courage to accept this, to face it on and just make a change. Because if you don't make that change, the change will be made for you. Ultimately, your displeasure in your work will start to come through. You'll start to make mistakes. It'll come at the expense then of your reputation, of your patient's health, your health, and your relationships. So be courageous and make a change. So if you've found something that you love, you're well ahead of the rest of the world. But recognize that even though 99% of the time you'll face each day and feel positive and ready to take on the challenges, this doesn't come by magic. It's based on hard work to get there, and it's based on maintained hard work to stay there. Like anything that's worth having, your dream career is built on the foundations of hard work, training, and sacrifice. To maintain that dream, you need to seek out or create the professional environment that supports you, balances the needs of your loved ones, and you need to continually keep the patients in the centre of your day for those of us who are clinicians. So no matter how much you love what you do, there'll be days that you question what you do and where the pressure and the challenges seem too much, but be prepared for those. Look after yourself. Ensure you maintain as much of a balance as you can. And when you think you don't have time for balance, that's probably the time you need it the most, and you need to carve out time to do something away from work. I hope you all find your bliss, but I also hope you come to appreciate the challenges that come with finding and maintaining it. To me, that's a life well lived. Thank you.
Well, I'm so, I've been thrilled with this session, and I really appreciate everyone putting their time in, and the talks were all spectacular. We are going to do hopefully a Zoom live discussion right now for the next 25 minutes or so. And I have, Luciana, are you on? And Sylvia, can you guys all hear me? And Gabby, all right, perfect, great. There we go.
Bear with us in the room in Miami. These speakers are standing. It's 2 in the morning in Australia. We've got speakers standing by wanting to talk to us.
That's so fantastic. And I think Luciana should be coming on as well. I don't see her. You know, I know all of us have questions. I had a couple of questions for, there's Megan. Hi, how are you?
Hi. Good, how are you guys?
All right. You know, I wanted to ask Luciana, but I don't see her yet. So I'm gonna, she's at the airport. Oh, well, I want to tell Luciana that she had a wonderful talk, and that her Zen, she's like a Zen master for all of her comments. I thought it was really fantastic, and really, I think, touched a core with everyone in the room as well. And I had wanted to ask her how she managed to figure this out in 20 years, because she's much more Zen than me. And I don't know if you guys think the rest of you, but I thought she had a lot of wonderful points. I would ask Wendy, you know, actually Natan is in the room as well. And he asked the other day, he said, why do you wake up? You know, and I told him, I said, I wake up for love, but I get up to do better. You know, so it's a thing that when you are looking at your bliss and what you do, you love. My kids see that now. Both my children want to be surgeons. Insanity. But you know, Wendy, can you speak a little bit to that? I loved your thing on, was that you or was it Aparna? Ikigai. I like that. Both of you maybe could speak to that.
Yeah, thanks. Look, thank you so much for including me in a really interesting session. It's like I think it's 2 in the morning here at the moment, and you've really kept me all captivated. So thank you so much, everyone. I've really enjoyed it. Look, I think we're so blessed. We have the most privileged job in the world. And as you say, you sort of get up for love, but you stay interested by what we do. I think that's a really wise thing to say. But I think I can't imagine a better job, really. Like we're so fortunate that we get to help people at times in their life when they really need us. And so that's, as long as you can always focus on what you're doing for a person and how you're helping them, I find that helps me get through any day, even when it's the worst day. And we all have really worst days. And even when it's days where I have to sit down and do my paperwork, which I also is kind of a really worst day for me sometimes as well. It just knowing that you're contributing to something good helps you keep going. And it helps me also then contextualize some of the sacrifices that we have to make along the way. And, you know, what a great testament that your kids want to be surgeons. Yeah, it is probably a little bit crazy, but it's obviously your joy in your job and in your life comes through. And I think that, yeah, that I don't know what you call it, the intercalating circle diagram was a really nice representation of what it means to find your purpose.
Actually, both Aparna and Wendy mentioned, I wrote down, Wendy said she liked being a surgeon because she was fixing people, but she also had the opportunity to create. And those of us that are friends with Aparna know that she's a beautiful artist. And I thought it was interesting how many of the speakers mentioned, you know, outlets and creativity as part of having a well-rounded life.
Marina, I have a question.
Natan has a question. Can you turn the mic?
Ladies first, thank you for being here. Thank you for a marvelous session. We really thank you, and people who are here are enjoying your session. I'm sure everybody online is enjoying it. I have a question for each of you, but it's the same question. So I watch all your presentation. I listen to all your presentation. I have this question. Anything you suggest to ladies going through the career? If a man comes to you, you will give the same suggestions, so you think there is a difference how you suggest to grow, to go to social media, to raise as a professor? Will you give different advice to them that you do to the ladies? And why and what you will say to the ladies different that you will say to your other residents, fellows, students? And thank you very much again for all what you did today.
Can we, yeah, it's a great question. Can we, Sylvia, let's start with you. We haven't heard from you yet, so.
Thank you, Nathan, for the question, which is really a good one, because I have, my team right now is only women except for one man, I mean, two, 1.5 men, maybe let's say it like that, and 2 of them are Arabic, from the Arabic background, which is a little bit challenging from time to time. And it's a really good question. I think we don't need to give these advices to men because they are more self-confident. And what I always realize that I personally don't feel that worthy myself. So, I mean, you all know me and we all like each other, but sometimes I think it's just me. I'm just, you know, just Sylvia, I'm just doing my job. And sometimes I think we women tend to forget what we can do, what we are worthy. Sometimes we just forget our values, and men don't, because of course they can manage situation, and of course they are good, and of course if a patient dies, it's not their fault, but the fault of the anesthetist or someone else's. But I think we as women do more reflect ourselves and always tend to find the problem with us. Maybe we should have done something in another way, and that's maybe the difference. But of course we tried, or I personally tried to have all my male colleagues to develop the same way. But like also, I think it was Aparna was telling us, they ask, okay, can I place the trocars? We women, we don't, we just a little bit wait, we are too shy. I don't know. And I mean, you all know me, I'm not shy, but sometimes I am.
Thank you, Sylvia. How about Gabby?
Hi, Marina. Hi, everyone. First of all, thank you for this kind invitation. A great question from Nathan. Well, what I can say is that the first thing you need to have is probably courage. as Aparna said in her talk, sometimes you have some opportunities and sometimes you don't take them because probably you are afraid to have a mistake or something. So the first advice that I usually do to my fellows or the even men, but more for ladies, is they have to take all the opportunities they can have. And for example, I can give an example. When I was starting my residence, I was going to be the only woman between about 20 men. And the professor that accepted me in the first interview, he told me that probably because I was going to be the only woman, all the things that I was going to be right, nobody was going to tell me anything. But if I do any mistake, everyone was going to know. And I need to work so hard and probably to do the double of effort comparing with the other residents. So probably something that I can say is that we need to work so hard to be constant and to have the courage to do everything and don't be afraid to have any mistake.
Thanks, Gabi. And then Aparna, and then Megan, and then Wendy. Aparna, you're on mute, I think.
Hi, can you hear me now?
Yeah.
Yes.
Yes. Thank you for the question. And I think men and women are wired very differently. And I do believe that men are not all sorted, and they also need help when they are juniors and when they are in their training period. But when it comes to women, especially when they are in surgery, they are a minority, and they definitely need a little more hand-holding because Gabi just said, that there are very few of us and we don't have enough role models. And I mean, there is nobody with whom you can share or with whom you can say things to. And I think by nature, women don't ask. They just hold back a lot of things. We also feel that we will just be given the due credit without asking. And men usually by nature do not hold back that much. Like I gave the example in my talk, they're just uninhibited. They just come and ask. And women are very inhibited, and they feel that, oh, I have worked hard in the ward. I have done my bit taking care of the patient, so I will be given my due credit on the OT table. But usually doesn't happen because people are busy, and it's not that they are discriminating against you, but it's just that if you don't if you don't ask for it, you're not going to get it. So that is the basic difference, and not everybody will understand that. So you have to ask. And that is a part of the training which should be inculcated in all trainees, I think men and women both. So that would be one thing which I think we should probably inculcate in all our trainee surgeons.
Megan, Dr. Jenkins is at NYU, and she's like a star at our institution, and she's in year 3 and already does the most robotic cases at our institution. I trained her, but I had nothing to do with her drive and ambition and skill. But Megan, what are your thoughts? And then I see Dr. Marquez is also on, so I would like to ask her as well after you, Megan.
Yeah, thanks. Of course, you have everything to do with me, Marina. This is an awesome panel. It's a great question. I think everybody's hit on stuff that's been super important. Obviously, men and women are different, right? We're not just different sexes, but I think we process a lot of things different. We go about life and our careers very differently. We have different demands. I think women are a lot more sensitive, like Gabi was saying and like Sylvia was saying. And I think one of the biggest things that I think, across the board, we kind of approach men and women the same way and give them the same advice about how to further your career, how to be happy in life, etc. But I think one thing that's important with women specifically is, like Gabi was saying, being courageous, right? Women are often a lot more subdued. We're not as outgoing necessarily, not outgoing, but in a different way. Men are very confident in everything they do, but I think women aren't necessarily as so, and they're not as vocal about it. think giving a lot more encouragement to women, telling them that they're doing a good job and giving them support when they're not necessarily asking for it, or they're not necessarily, saying confidently that they're, doing these wonderful things or helping all these patients, is something that's really helpful. I think Marina did that for me a lot in my first few years in attending. It's been really something that, I would never ask for it because, it's not it's not our nature necessarily, but it's been something that's been really valuable. So I think for young women in their training and early in their careers, giving them that support is super, super helpful.
One second. And then Michelle. Thanks, Megan. And Michelle?
Well, I think everyone has different times because you may have more practice, more skills, or maybe more ability than others, and you will have to create your own learning curve based on that. I think you will have to surround yourself with people with more experience than you every time and listen all the advices of your professors. You will have to create your own technique and your own technology when you are ready to start alone and try harder than others, like Gabby said. And you will have someday to get out of your comfort zone and take a lot of risks and practice all the time and be updated of yourself every time because opportunities appear only one time. And of course, if you want to be successful, you will need to surround yourself with successful people. I think so.
Thank you so much. And then Wendy, and then we have a question from the floor.
I think it's a really interesting question, Natan, and probably the way I would have answered it a few years ago would have been different to how I answer it now. I'm chief of surgery at my hospital now. I'm program director, so I'm in charge of all the surgical specialties, orthopedics, neurosurgery, trauma. And I guess what I've discovered is that it's not so easy just to break it down by gender. It's down to the individual. So, in my specialty, in my hospital, there's a lot of women. But that might just reflect, that my mentors before me sort of supported us and gave us opportunities. And a bit like Sylvia in my unit, there's, most of our trainees are female, most of our researchers are female. But in some of my other units I look after, there's very few women. And so I think it's about being sensitive to, I have a responsibility not just for my female trainees, but also for the males that are in our program. And it's about understanding what each individual needs. And I have to say, not every male is really brave either. There's a lot of guys that don't fit the stereotype. And I think they should have the opportunity to be surgeons too. So I think it's about finding the right people for this job that we do. We shouldn't all be the same. We should all bring our own special characteristics to the job so that we can deal with a very broad population that we're serving, because, it's horses for courses. Not every patient's going to like you, but they might like the person up the corridor, and that's fine. And so I would give the same advice probably to men and women, but what I would encourage them to do is to find a mentor that they relate to, that inspires them, that makes them want to come to work and wants them to be better. And I do think, we do have to take into mind everyone's special contribution that they can bring and try to tailor their training around them so that they can be the best surgeon they can be into the future.
Well said, Wendy. Thank you. Luciana and Michelle both said something along the lines of surround yourself with people that are better than you are. Everybody needs advisors. To your point, we've got a question in the room from Camilo. Yes, sir.
Hi. Congratulations. Thanks. A very, very nice session. Very interesting. I woke up. Thank you, Marina. I have two questions. One is, what is the worst thing you have faced or you think is that men do in terms of the relation in surgery? What is the thing that we should really avoid? And what is the best thing that that men do in terms of surgical relations? Or what does woman really said, oh, that's a good thing?
Wow. Okay. I don't know if our panel wants to jump on that. I think it is regional. I think there's a lot of differences depending on which part of the world we're in, or even which part of the country in the U.S. that we're in. And I will say, I'll just, and maybe you can all agree or not. Yeah. Yeah. My best thing is some of my best mentors have been men. Worst thing, You guys all know me. I don't tolerate the interruptions or things like that if I'm speaking, but that is something when you're in a meeting and you're talking, that when people talk over you or ignore your suggestions, I think that's not right. And that's not something I would do to any one of my colleagues, so I wouldn't expect it in return. Let's start with Gabby. You're on the top of our screen, Gabby, so you first. If we can do it fast. Best and worst thing that men do.
Well, I can probably say many examples. Well, some important thing that probably I don't like too much. For example, when we are trying to do something during the surgeries, when you are doing an operation between other men, probably it's very usual that as courtesy they want to help you. Then they don't note that at this moment you are probably the surgeon and you can resolve anything, to do many things during the operating room. And sometimes I am talking about minimal things, like, for example, to put some something on the table or something, not specifically during the surgery, but they want to help you, and then they are doing as courtesy, but at the same time they are giving the message that they can do it and you can't. I don't know if this you can understand. And the other thing, as Marina says also, is that when you are talking and you are doing your opinion, sometimes they are trying to do another opinion, trying to be someone who, how can you say, that they are having the reason and you don't have any reason about what you are defending. And the best things that they can do, for example, I have many examples during 4 years that I was working in a public hospital where probably the machismo was more focused, was that probably some of my partners were telling me if I was okay, if I need some help, or if they can do something for me when I was probably, how do you say, crossed with some things. But I think that in general, you need to be polite with the people. I don't know if I could answer very well.
Thanks, Gabby. We're gonna, how about you, Megan? Rapid fire.
Yeah, rapid fire. So I agree, Marina. I think, men can be fantastic mentors and they can also help push us to be better, right? Surround yourself by people who are, better than you. And I think there are a lot of fantastic male surgeons. There's a lot of fantastic female surgeons, but there's also a lot of fantastic male surgeons. They can help push us to get better, be our best selves. They can help us grow too. Things that they, sometimes are the worst things. I've definitely had experiences where I've had male residents, I've gone rounding with them and the patients assume that the male resident's the doctor. And instead of acknowledging that and telling the patients, no, this is actually your attending or your physician, if they kind of play into those kind of stereotypes, that's something that is sometimes, detrimental to us as female physicians. I think that that's a big one that I can think of. It doesn't happen often. There's a lot of men who are very supportive of women, obviously, but that's one I can think of. That's my rapid fire.
We're running out of time, and I actually asked Marina for the opportunity to answer Camilla's question. So it's the privilege of the podium that the co-moderator gets to say best and worst. Am I allowed to just acknowledge that I many times was sexually harassed, asked out, hit on, overtly sexual comments. Too many to even list. So that's what not to do. And the best thing that men can do is include us. We like to be where you are. We like to participate in scientific sessions. We like to go with you when you're going out afterward. Please invite us along. We want to be with you.
All right. Thank you all. Thank you, ladies from all over the world, Dr. Marquez, Dr. Basker, Dr. Brown, Dr. Jenkins, Dr. Wiener, Dr. Maldonado. Thank you so much. And thank you again to Ifso. We are going to take a 5-minute break and then the last session will start. Thank you.
Thank you so much. Thank you.
That's great. Now they're going to ask you to go out till 3 in the morning.
Con el comité científico yo me para que
top papers. When we have to postpone the meeting, one person remove that paper. So we're gonna present 9, the top papers. And I'm honored to have the people who are gonna moderate this session. They are all online. And here locally, we're gonna have Dr. Calpesta that is gonna help us locally in case there is a problem online.
So our panel here is Lilian Cao, President of Ifso from Australia, Dr. Scott Chicora, President-elect of Ifso from Boston, and Miguel Herrera, President of the Scientific Ifso Committee. I can see you all guys now. Thank you very much for being part of here. And they will be discussing the papers here today. And Carpesta is gonna come and help us locally in case if something is needed. So I give the word to you, Lilian, Scott, Miguel. You are in the podium, you are the bosses for this session. Thank you for all your help and support to the meeting. We are very happy here locally. And Manuela told me that online we are very happy too. So welcome and we can start.
Well, thank you, everybody. It's a pleasure to be part of this and to work with Professors Cao and Herrera. The way I understand this happens is that each speaker has 7 minutes to present their abstract, and then we'll take questions for 5 minutes, and then we'll move on to the next one. So we need to stay on time. If anybody has a longer presentation, please go through it in the time allotted. Miguel, Lillian, words? Anything to add? Can't hear you. Hello?
Hello,
All
good
right.
morning. I was muted. Lilian, go ahead, please.
Hi, everybody. It is my pleasure as well to be with all of you. I'm very excited with this session where we're going to look at the top 10 papers. So very glad to be here and looking forward to this session.
All right, well, I will introduce the first abstract. It is by Dr. Nicholas Sin, and it's the Association of Metabolic Bariatric Surgery with Long-Term Survival in Obese Adults with and without diabetes, a patient-level meta-analysis of 174,000 patients with 1.2 million years of follow-up. Dr. Sein, you're up.
Thank you very much for the honor to present at the Ifso 2021 virtual meeting on our topic, Association of Metabolic Bariatric Surgery with Long-Term Survival in Adults with and Without Diabetes. I am Asim Shabir from the National University Hospitals, Singapore, and I'd like to thank everyone on behalf of my co-authors for accepting our paper. I have no conflict of interest to declare. It is impossible to do a large study because it would require a large number of authors, patients with longitudinal follow-up to demonstrate a difference. And this is, it would take a long time and it would be very cost expensive. So what we have basically done is to try and study metabolic bariatric surgery versus usual care, trying to find out any differences in all-cause mortality, extrapolated life expectancy, potential number needed to treat to prevent death, and compared obese patients with or without diabetes. We searched the web and we found 1,362 articles, of which 17 studies were included in this study. Patients were matched so as to avoid confounding. The Kaplan-Meier curves from each study were deconstructed to give individual patient data and then reconstructed to do one-stage meta-analysis. The survivals are extrapolated to give 30 years and beyond survival. We had 174,772 patients in the study, mostly about 40 years and above of age, with a median of about 70 months of follow-up. The overall mortality reduction is 61.5%. And you can see at 30 years, about 46% in the usual care arm had lost their life compared to close to 30% in the surgical arm. The life expectancy gain was 6.1 years in metabolic bariatric surgery versus usual care. When we look at obese patients without diabetes, the risk reduction in death was about close to 30%. And you can see still a difference between surgery versus medical therapy still persisting at 12 years. Numbers needed to treat were close to 30 to prevent one death at 10 years. And the median gain in life compared to usual care was about 5.1 years for metabolic bariatric surgery. When we compare patients who are obese with diabetes, the reduction in risk of death was close to 60%, which is very profound compared to usual care. And if you look at 20 years out, the surgical arm had lost about 21% of patients, whereas the usual care arm, which includes medical therapy, which includes use of endoscopic measures apart from lifestyle intervention, had lost about 35.2% of patients. The median gain in life following metabolic bariatric surgery in obese with diabetes was 9.3 years, and we required to treat only 8 patients to prevent 1 death at 10 years. There were no differences in survival comparing Roux-en-Y, LAGB, and sleeve gastrectomy. If the penetration of bariatric surgery was assumed to be increased by 1%, considering the world population to be 184 million, with 30% being diabetic and eligible cohort, we will have about 55.2 million patients that we could potentially treat. And when we increase the penetration of bariatric metabolic surgery by 1% utilization, in those patients who were obese with type 2 diabetes, it would have yielded 5,133,600 future potential life years. In those without diabetes, it would have yielded 6,568,800 future potential life years. In summary, if we look at patients who were alive at 30 years, in the surgery cohort, they were close to 61%, while in non-surgical arm, they were close to 54%. Metabolic surgery for the obese diabetic patients resulted in a 60% reduction in mortality compared to 30% in the pure obese group. The numbers needed to treat were 8 to prevent 1 death at 10 years in diabetic cohort with obesity, and those without obesity, about 30 patients. Thank you very much for your kind attention.
Thank you. That was a wonderful abstract, very well reported. I have to mention that the person who gave the abstract is Asim Shabir, not Nicholas Sin. So I apologize for looking at an old schedule. I'd like to ask you the first question. These numbers are huge, which you were referring to as far as numbers of patients. Can a lot of countries afford to provide that many operations, even though they'll benefit in the long run? Do they have enough money to allow this much surgery to go on?
Thank you very much, Professor Shikora, for that question. The resources definitely lie because it is one of the interventions that has been shown to be cost effective in the long run. There are these cohort of patients that can be supported. Can the bariatric surgery be increased by 1% across the globe? Certainly, there's a lot of potential, especially in the first world countries. Even in the third world countries, there are a lot of people who could, we know that it would ultimately pay for itself within 6 to 7 years of intervention. So compared to usual care. So I think there are resources available, and yes, people can afford. The cost of surgery in different countries is different, and adjusted to it, people can afford it, most certainly.
All right, the floor is open to other questions. Does anybody have any questions? Yes.
None from the floor here, Dr. Shakur.
Okay, let me ask you one more question. Along those same lines, resources, hospitals, hospital beds, ventilators, increasing 1%, even that small number, there's going to have to be dramatic purchasing of equipment and expansion, as we had seen with the virus. Is that something that you think the countries have the stomach to do? Or do you think they'll just opt and let the patients suffer as they are now?
So I guess in terms of resources, recalibrating ourselves, the penetration of laparoscopic surgery across Asia and other continents over the globe is quite well known. A lot of institutions have laparoscopic instruments, and for bariatric surgery, the infrastructure really needed is not very much beyond what already exists in many hospitals, no matter where they belong to, whether to belong to poor nations or they belong to rich nations. And certainly there would be a crunch in third world countries where maybe the capital equipment is more expensive, but they do have other alternatives which can be sourced at cheaper cost. And when there is a driving force, a market driving force, I think that can easily compensate and incentivize the private sector to take on the load, and patients would be willing to invest if it's really safe. So I don't per se see a problem. You can see bariatric surgery coming up in countries like India, countries like Pakistan, Iran, Sudan, and all these places. So they do have resources and people are willing to spend for their healthcare.
Great. Thank you very much.
We have one quick question, Dr. Shakur. Do we have time for one quick question from the floor?
Lillian or Miguel, do you want to ask the last question?
I'd just like to make a comment. I like the numbers, Asim, that you put out to us with 1 million of years of follow-up and patients. It really reinforces the positive effect of bariatric and metabolic surgery. So I'd like to thank you for your paper.
Thank you very much for the comments, Madam President.
Thank you for presenting.
One small question, Asim, congratulations, very nice paper. Do you have aware of any, because someone was saying that it would be very costly and very expensive to implement this, but probably are you aware of any studies on how much we are spending in treating diabetes and all the complications of diabetes that we are probably today 70% of all the patients in a hospital has some form of spending money on diabetes consequences, renal failure, dialysis, etc. And I think that's the cost analysis we should do.
Thank you. Thank you. Interesting way of looking at the cost effectiveness of bariatric surgery to look at the cost to treat complications of diabetes. I do not have the figures offhand, though a long time back I did do one analysis, but I can't remember it off the top of my head. But certainly something that we together can make an effort to do, and certainly something to look forward to.
Very well said. All right, we need to move on. The next abstract is titled Randomized Trial of Ursodeoxycholic Acid to Prevent Cholecystectomy After Bariatric Surgery by Dr. Silke Hal.
Welcome everybody, my name is Silke Hal and I'm happy to present you the results of the UPGRADE trial. I have no disclosures. Bariatric surgery is a safe and effective treatment option for long-term weight loss and reduction of obesity-related diseases. A common complication, however, is gallstone disease. Although international variation exists, cholecystectomy at the time of bariatric surgery is in general reserved for patients with symptomatic gallstones prior to surgery. The use of UDCA and oral bile acid is still debated. There is evidence that UDCA can prevent gallstone formation during rapid weight loss, but since most patients remain asymptomatic, gallstone formation is not a clinically relevant endpoint. The UPGRADE trial was conducted to provide evidence whether UDCA is also able to reduce the occurrence of symptomatic gallstone disease after bariatric surgery. The upgrade was a double-blind multi-center RCT in which bariatric patients with an intact gallbladder were included. Prior to randomization, a gallbladder ultrasound was performed to determine the presence of asymptomatic gallstones at baseline. Both patients with and without were included, and the result of the ultrasound was blinded for the patient and treating physicians. Patients were randomly assigned to receive UDCA for 6 months or placebo, and the randomization was stratified for the presence of asymptomatic gallstones at baseline and for the type of surgery. The primary endpoint was symptomatic gallstone disease within 24 months. Unfortunately, I only have the time to discuss the need for cholecystectomy and the safety today. The analyses were performed in the modified intention to treat population, and the chi-square test was used to evaluate whether proportions differed significantly between the groups, and the logistic regression to test whether the effect of UDCA differed between subgroups. The results. 985 patients were randomized, of whom 13 did not receive the assigned intervention because eligibility was violated. Another 5 patients did not have a post-randomization measurement, leaving 477 patients in the UDCA group and 490 patients in the placebo group. 8 of them had incomplete follow-up, which precluded primary endpoint assessment at 24 months. The study population was representative for a bariatric population. In 20% of the patients, asymptomatic gallstones were diagnosed, and most patients received a Roux-en-Y gastric bypass. As you can see, therapy compliance was moderate in both groups. Did we observe a difference in the occurrence of symptomatic gallstone disease? Symptomatic gallstone disease occurred in 6.5% of the patients in the UDCA group compared with 9.7% of the patients in the placebo group, which gives a relative risk of 0.67. However, the upper limit of the 95% confidence interval above 1 shows that this difference was not statistically significant. The logistic regression showed that there was a significant interaction between UDCA and the presence of asymptomatic gallstones at baseline, which was not the case for type of surgery. This significant interaction means that the effect of UDCA differed between patients with and without asymptomatic gallstones at baseline. And in this table, you can see what this interaction exactly means. In the second row, you can see that we observed a beneficial effect of UDCA in patients without, and in the third row that we observed no effect in patients with asymptomatic gallstones at baseline. Was there also a difference in the number of cholecystectomies? Yes, even in the entire study population, the number of cholecystectomies was lower in the UDCA group. And moreover, the protective effect of UDCA was even stronger in the subgroup of patients without gallstones at baseline. Were there any safety concerns? No. During the trial, no safety concerns were noted. Now that I've shown you the most important results, I would like to discuss 4 discussion points. First, we have enrolled patients with asymptomatic gallstones in baseline because in current practice, they receive in general no other or extra treatment. However, we did not observe a beneficial effect of UDCA in these patients. Based on the numbers needed to treat, we consider the administration of UDCA desirable in patients without gallstones at baseline. Third, efforts to improve therapy compliance should be made. And last, although we did not observe a significant interaction between UDCA and type of surgery, our results cannot be extrapolated to patients who underwent a sleeve gastrectomy. A similar effect of UDCA is expected, but this should be confirmed in a second prospective study, which is adequately powered. In conclusion, does UDCA reduce the occurrence of symptomatic gallstone disease after bariatric surgery? Yes, in patients without gallstones prior to surgery. I would like to thank the participating hospitals and the funders. Are there any questions?
Trial, one question I have is, in the group that was in the control arm, how many of the patients who developed stones developed the complications of stones, such as gallstone pancreatitis, cholecystitis, problems of that nature? Because otherwise, if you're preventing someone from just forming asymptomatic gallstones, are we really investing the money wisely? Because if they're asymptomatic, they're asymptomatic. So do you know how many patients actually had complications?
Hello, everybody. Thank you for the question. I think just a minor part of the patients who were symptomatic experienced a complication. I think most symptomatic patients just had a biliary colic. And I think, yeah, I don't know out of my head, but it was just a few. I think 85%, maybe even 90% of the symptomatic patients had a biliary colic.
But you didn't have any that had more serious complications?
Just a few.
Okay. One other thing is that you may know in your reading to prepare this that Harvey Sugarman did a study like this back in the 90s and found that URSO also reduced the formation of gallstones, but the compliance was very poor and it never caught on after that. So I noticed your compliance numbers weren't very high, 5 or 6%. How did you get so many patients to take these medications that often would cause nausea or bloating, GI symptoms? Because we couldn't in the US.
Yes, I know that paper very well. I think even in our trial, the compliance was not that good because I think it was 63% overall. Yeah, that's a real problem with UDCA. But I think the biggest problem our patients experienced is that the tablets were quite big and that it was hard to swallow them. I think most patients didn't really complain about like any nausea or bloating or stomach pain. So it was actually the size and the type of the tablets.
Okay, I'd like to open this paper up for discussion. Anybody at the meeting like to ask a question, or Professor Herrera, Professor Cao, do you have any questions for Dr. Howell?
Dr. Howell, I'd like to ask, what is the cost of URSO in your country? Because in some countries, the cost is quite prohibitive.
Yes, I think if UDCA is going to be like prescribed afterwards, I think the insurance will pay for it. So it won't cost patients any money afterwards, after the surgery. And we're still working on the economic evaluation actually, but it will cost, it depends on the dose, but I think it will cost like €2 or €3 a day.
Thank you.
Professor Herrera, any thoughts, questions? Anybody in the audience would like to speak up? Now's your chance.
Yeah, for anybody at the meeting here, just a quick show of hands, who's using it currently in their patients? You can kind of see on the screen. Okay. Thank you.
Well, thank you very much.
Thank you.
The next presentation, I understand, is a video presentation. It is by Dr. Aristides Dumoras, and it's the abstract is entitled Bariatric Surgery as a Secondary Prevention for Cardiovascular Disease, a population-based matched cohort study in a universal healthcare system. So if we could run the video.
Hello, and thank you for attending the Ifso Top 10 paper session today. My name is Dr. Aristides Dumoras. I'm a bariatric surgeon at St. Joseph's Healthcare and McMaster University in Hamilton, Ontario, Canada. And I'm here to present bariatric surgery and cardiovascular outcomes in patients with obesity and cardiovascular disease, a population-based retrospective cohort study. I'd like to thank all of my co-authors, as well as all of the institutions above that helped make this work possible, especially Ontario Bariatric Network, McMaster University, St. Joseph's Healthcare in Hamilton. For those of you who don't know, this paper was published this year in April in Circulation with another excellent paper by Dr. Naslin's group out of Sweden, an opinion piece by Dr. Phil Schauer. I have nothing to disclose. Obesity is associated with an increased incidence of heart failure, myocardial infarction, stroke, and death. Bariatric surgery, as most of you know, has been shown to significantly reduce cardiovascular risk factors. However, whether surgical weight loss can reduce major adverse cardiovascular events, or MACE, especially in patients with established cardiovascular disease, remains poorly understood. Therefore, we aimed to examine the outcomes of patients with both CVD and severe obesity undergoing either bariatric surgery or routine clinical care in Ontario, Canada. This was a population-based matched cohort study of numerous linked databases in Ontario, Canada, the main of which was the Ontario Bariatric Registry and a family medicine database. Patients with obesity and heart disease who underwent bariatric surgery were matched via propensity score to non-surgical controls. They were matched on more than 25 important clinical variables, including heart disease and heart failure. To evaluate the primary outcome, we used a cost proportional hazard model. The analyses were divided by heart disease status, sex, BMI, age, and by procedure to look for effect modification and whether bariatric surgery affected different groups differently. Our primary outcome was an extended MACE of all-cause mortality, myocardial infarction, coronary vascularization, cerebrovascular disease or cerebrovascular events, and heart failure hospitalization. Overall, we identified 2,638 patients, or 1,319 in each group, with a median follow-up of 4.6 years. For all patients, the entire cohort, the primary outcome occurred in 11.5% of the surgery group and 19.6% of the controls, and a 42% reduction in the adjusted hazard ratio. For heart failure patients specifically, they had an adjusted hazard ratio of 0.44 and a very large absolute risk difference of 19.3%, which translated to an event rate of around 38% in the control group and 19% in the surgical group. For those with ischemic heart disease, the adjusted hazard ratio was 0.6 with an absolute risk difference of 7.5%. These four panels demonstrate the cumulative incidence curves for each. In the top left, it's the overall cohort and the primary outcome. In the top right is the ischemic heart disease patients with the primary outcome. The bottom left is the heart failure patients and the primary outcome. And the bottom right is the overall cohort for the secondary outcome, which was more serious measures of MI, stroke, and death. Overall, bariatric surgery was associated with a 42% lower observed hazard ratio in the primary outcome. This was seen in the overall cohort, as well as in the heart failure and ischemic heart disease cohorts, respectively. There were several limitations to this study, and as an observational study requires confirmation by a large-scale randomized control trial. Of note, we are starting a large-scale randomized control trial in Canada, so if there's any interest, please reach out. Overall, this study demonstrated that bariatric surgery was associated with a significantly lower incidence of MACE in patients with CVD and severe obesity. This analysis was able to address a major gap in literature, and this study provides novel information, requires confirmation by large-scale RCT. Thank you so much for listening.
Throw out the first question to you. It's actually a two-part question. I'm sorry if I missed it, and maybe you stated it, but was there a difference between gastric bypass and sleeve for these patients? And secondly, yes, we know from the literature and from this study that you can improve outcome for these patients. They can now get on the transplant list, or in fact, some of these patients could have the pump removed and their heart recovers some after surgery. But what about operative risk? Did you see a difference in operative complications or perioperative complications between this group and another cohort, say patients without such severe heart disease who have bariatric surgery?
Professor Chikora, the author is not here with us. He only sent his presentation because he was not able to be with us today.
Okay, so we'll move on. That was such a good question also. Anyway, the next abstract that we're going to present is the long-term effect of Roux-en-Y gastric bypass versus sleeve gastrectomy on reflux and Barrett's esophagus, a randomized controlled trial. Dr. Ahmed Barazanchi.
Present. I'll be looking at my study examining reflux and Barrett's esophagus after bariatric surgery. The findings declared on this page. Sleeve gastrectomy is the most common bariatric operation. It's recently outranked Roux-en-Y gastric bypass as the most popular procedure. It offers reasonable weight loss, improvement in metabolic outcomes, and it's relatively easy to perform. One of the issues with sleeve gastrectomy is the potential worsening of existing reflux and the development of de novo gastroesophageal reflux. In a recent meta-analysis, there was a recorded 8% Barrett's esophagus long-term after sleeve gastrectomy. On the other hand, Roux-en-Y gastric bypass is seen to be an anti-reflux procedure, and in fact, in some cases, is seen to regress some Barrett's. We examined a study back in 2017 at our centre. It's a double-blinded, single-centre randomised controlled trial comparing laparoscopic gastric bypass and sleeve gastrectomy. The gastric bypass was performed in routine fashion with 100 centimetres anticolic antigastric Roux limb and a 50 centimetre BP limb. The difference between this and a standard bypass is there was a 6.5 centimetre silastic ring put around the gastric pouch. The sleeve gastrectomy was routine, performed over a 36 French bougie. We included adult patients, BMI 35 to 65, that all those patients were diabetic. Barrett's esophagus is a pre-malignant condition. It's defined as a presence of metaplastic columnar epithelium. It's been associated with esophageal adenocarcinoma. The definition differs in the literature. De novo Barrett's after bariatric surgery is not well characterized, and its risk in relation to long-term cancer is poorly understood. We define Barrett's esophagus as both endoscopic and histological findings. The endoscopic findings were classified according to Prague classification. The histological findings were the presence of intestinal metaplasia. We did not require the presence of goblet cells for our study. We required both a blood test as well as questionnaires prior to the endoscopy, and then we performed an endoscopy performing routine biopsies. There was a pro forma at the time of the biopsies, so we ensured that completeness of the biopsies was performed. Those biopsies were for all patients despite any findings. They're GOJ biopsies, mid-esophagus, antrum and pouch, duodenal and jejunum. Of the 114 patients that were originally consented and underwent the initial trial, 109 surviving patients were contacted. 48 of those patients accepted undergoing this further sub-study. 26 were in the sleeve gastrectomy group and 22 were in the bypass group. There was no demographic differences between the age, the follow-up or the follow-up duration, which was about 7.5 years. The preoperative BMI was the same. However, the sleeve gastrectomies had significantly higher BMIs at the 7-year mark than the Roux-en-Y gastric bypass. A similar pattern was reflected with the HbA1c level, which denotes the control of the diabetes. For our primary results, sleeve gastrectomy had 6 patients out of the 26 having Barrett's esophagus, whereas the Roux-en-Y gastric bypass group, only 3 of those patients out of the 22. When looking at long or dysplastic Barrett's esophagus, there is no significant difference between the two groups. Examining the reflux questionnaire, interestingly, Roux-en-Y gastric bypass had worse reflux as well as worse regurgitation than the sleeve gastrectomy group. This may be in part due to the silastic ring. Esophagus are much higher than the noted literature. 23% of our sleeve gastrectomy group had Barrett's esophagus. When we exclude the ultra-short segment of Barrett's esophagus, we still have 19% of the sleeve gastrectomy groups with Barrett's. 30% in the Roux-en-Y gastric bypass had Barrett's. Only one of those patients, however, had dysplasia, and that's a patient with metastatic RCC. The higher rates may be related to the fact that all our patients were diabetic and thus relatively immunocompromised. Also, we've followed up the patients at 7.5 years after the operation. Interestingly, our Roux-en-Y gastric bypass group also has Barrett's, and we're not sure why the rates are so high with the Roux-en-Y gastric bypass. We have, however, routinely taken biopsies of the GOJ, so we might have detected at higher rates. Long-term incidence of Barrett's esophagus tended towards a sleeve gastrectomy group, but the results aren't statistically significant in our study. In the obese patients with type 2 diabetes, quite a high rate of Barrett's esophagus is noted postoperatively, and we recommend routine screening for these patients with endoscopies postoperatively. Thank you.
Is our speaker available for questions?
Hello, can you hear me?
Yes, we can. Yep.
Can you see me now as well? Hi.
Yes, congratulations. Great paper. Any questions from the floor here in Miami? We have a question. Go ahead. Yeah, Dr. Kurian has a question for you. Here you go.
When you looked at the bypass population and that it was so high, 13% incidence of Barrett's, was there any way for you to determine if the size of the gastric pouch was standardized? I mean, obviously it's so hard to measure, right? But was there something, was it a really long pouch? Was it, you know, were there any elements of that construction that you could tease out?
The size of the pouch was aimed to be about 20 mils. It was a reasonably consistent size in terms of how it was surgically performed. So that was sort of standardized by the operating surgeon. In terms of why we've got such a high rate of Barrett's, the only difference is that there was a silastic ring that was used, and at that stage when the trial was made, a 6.5 centimeter silastic ring was put. So that was quite restrictive. In fact, at a later stage, it's a 7 centimeter silastic ring that's used by the particular surgeon that's in that unit. So it's potentially that regurgitation effects from the silastic ring that we might be seeing with the is why we have such a high rate of Barrett's with our Roux-en-Y gastric bypass. That's just one theory.
Thank you. Dr. Wilson has a question.
A great talk. So also, when you did these endoscopies with the banded bypasses, how many times did you see the band eroded inside? Was that noted?
None of the cases that was eroded, and in fact most cases the standard endoscope went through just fine. With the paper we just had a few more rates of regurgitation and reflux, but it had a good restrictive effect, so they lost more weight and that was significant.
Ahmed, I enjoyed your paper. This is Lillian Kell. I have two questions. One is, did you correlate the symptoms of reflux pre-operatively and at the time of your investigation with these patients? And did these patients have a pre-op endoscopy?
Yeah. So the correlation with these patients is poor. The record in terms of whether or not they had reflux beforehand wasn't as accurate as we were hoped, and also the endoscopies were not performed. So it's unknown whether this was de novo or whether this was a new incidence of Barrett's, but in the controlled settings, these patients were randomized and blinded, so you'd hope that the baseline rates would probably be similar as most of the demographics were. But yes, it's an absolute unknown. Thanks, Louis.
Thank you.
Any other questions? Dr. Herrera?
Okay, I will introduce the next paper.
Thank you.
Thank you very much. The next paper is named Long-Term Results of Primary SADI-S and will be presented by Dr. Sanchez Pernaute, Rubio, Perez Ferre, Marcuello, Talavera, and Perez Aguirre from the Hospital Clínico San Carlos, Martín Lagos in Madrid, Spain. Go ahead, please, Dr. Sanchez Pernauti.
Good afternoon from Spain. Thank you for having me in. We have been performing SADI-S in 2007, so it's almost 15 years doing the operation. And after all these years, we can have some questions to answer about the operation's results. The first one would be if the elimination of the whole limb has affected the long-term weight loss of a previously successful operation, the DS, and if there is any benefit with the elimination of one anastomosis. So to answer these questions, I will present the series of patients operated before December 2015, so they have at least 5 years follow-up completed. We submitted to surgery in those days to almost 200 patients, but we discard 35 submitted to the operation as a second step. So we will leave for this analysis 164 primary SADI-S. Mean age of the series was 47 years, mean weight 124, mean BMI 46. There were more women than men. 60% of our patients were diabetics, 55% had hypertension, 50% obstructive apnea, and 72% dyslipidemia. The initial operation consisted on a duodenal switch with one anastomosis and a common channel of 2 meters. This was performed in 50 patients. Then we changed to longer limbs, and we include 99 patients with a 250 centimeters common limb and 15 patients with a 3-meter common limb. The anastomosis was stapled in 106 patients and hands-on in 58. As post-operative complications, we had 1 gastric staple line leak, 2 anastomotic leaks, 1 was reoperated, 1 intestinal perforation, 2 hernias, 1 gastric bleeding. There were no deaths, and 14% of our patients came back in the first post-operative month to the emergency ward, but only 3% of the total series were readmitted, mostly because of fever. Follow-up was complete at 5 years for 84% of the patients and at 10 years for 75% of the patients. Excess weight loss was 88% at 5 years. Total weight loss was 39%, and BMI at 5 years was 28. And these numbers came to 80% excess weight loss, 34% total weight loss, and 29 final BMI at 10 years. And the rate of failures patients who did not achieve a 50% excess weight loss was 11.9% at 10 years. And these numbers were quite similar to those reported by Doug Hess in the late 90s. Resolution of comorbidities was, as expected, also very good. It is remarkable to see how glycemia and A1C mean values were almost normal at 5 years and 10 years. And it is very interesting to see how patients needing insulin preoperatively were 83% of them were free of insulin at 5 years, and 70% of them didn't need insulin at 10 years from surgery. Patients should be supplemented for life, mainly with vitamin D, calcium, and iron, but also micronutrients. And in spite of this, at 10 years, we still detect some abnormalities, mainly in vitamin D, parathormone, and vitamins A and E, and some other micronutrients. The number of bowel movements is almost normal, 2.4 at 5 years and 2.1 at 10 years. And considering the whole series of more than 400 patients, the reoperation rate related to the first surgery is 7%, which is much lower than the reported one after worldwide gastric bypass or sleeve gastrectomy. One patient was reoperated for GERD in this series, and when we analyzed endoscopies performed, only 8% of our patients have grade C or D esophagitis, and no patient has a newly developed Barrett esophagus. In the follow-up, we have had 11 deaths, mainly because of respiratory disease, but also because of malignant neoplasms. And we still have 4 patients alive with neoplastic disease for a total tumor rate after the operation of 4%. Also, 4% of our patients have nephrolithiasis because of hyperoxaluria, more frequently seen in patients with shorter common limbs. The only factor that we have found related to weight loss is the length of the common limb, as patients with a longer common limb, 300 centimeters, obtain a poorer weight loss in the long term. So to conclude, we can say that SADI-S is an easy and safe operation because it has a low rate of post-operative complications. The results are homogeneous for different kind of patients. The limbs should be, the common limbs should be at least 250 centimeters in length. And in this way, we will have a low rate of nutritional issues and a good quality of life. So selecting adequately the patients, following them and supplementing them will give us a safe operation, effective operation, and efficient operation. So I recommend you to switch to SADI-S. Thank you very much, my friends.
Any questions from the floor here? Dr. Cal Herrera Shakura?
Yeah, I have a question. I enjoyed your paper very much. Thank you. I just had a question about your leaks in the post-operative period. Were they in the redo patients or were they for the primaries?
Thank you, Lillian. This series only includes primary patients, so all leaks were in the primary patients. In redo patients, we have not a single leak.
Okay, thank you.
Yeah, I have a question.
One question. You
Sure.
mentioned that you had 11 deaths over the span of the time of the study. My program does about 600 or 700 cases a year, and we haven't had 11 deaths in the decade. What's the thinking from your program why 11 people out of 199 have passed?
Well, thank you. Well, the reasons for death, I exposed them to you. 4 cases were because of end-stage respiratory disease. We had one patient in the waiting list for a lung transplant. We had one patient with Steiner disease. One patient who needed respiratory support and he refused it, and I really don't remember the 4th one. And the other cases were neoplastic diseases, and we had some patients dying because emergency surgery. So that's our rate, and we have investigated all patients as deep as we could.
Thank you.
Thank you.
I have a question for you, Dr. Sanchez-Pernauti. Have you analyzed the impact of the different bowel lengths on nutritional markers and supplement requirements?
Thank you, Miguel. Really, I cannot give you the statistical difference, but I can tell you that patients with SADI-S with a 3-meter common limb almost do not need any supplement. They behave almost with like sleeve gastrectomy patients. They do very well. Patients with a limb length of 250, that's our current length, as you know, need usually vitamin D, calcium, and iron. And patients with shorter common limbs, as we did in the past, need usually more micronutrient supplementation, mainly copper, selenium, zinc, and so on. And that is a dangerous operation. But I cannot give you the exact statistical difference between all lengths. I think our current length 250 is safe, and it's quite safer, but gives a poorer weight loss, a 3-meter common limb.
And my second question would be, now that you know the pros and cons of the different limb lengths, what is your recommendation for the standard SADI?
250.
Well, is there any other question from Lillian, Scott, or the floor? Okay, we will move. Thank you very much, Dr. Sanchez-Pernauti. We will move to the following paper. And the name of the paper or the title is Outcome Evaluation of Revisional Surgery for Malnutrition Following SADI-S. And it's presented by Dr. Laces, Saez, Lopez, Martin, Garcia, and Panella, the same hospital, the Hospital Clínico San Carlos, Madrid, Spain. Go ahead, please, Dr. Laces.
Good afternoon, I am Viviana Laces and I'm going to talk to you about the outcome evaluation of revisional surgery for malnutrition following SADI-S. SADI-S is a hypoabsorptive surgery which was first described with a common channel of 200 centimeters that then was increased because of the high rate of malnutrition in the initial series. Malnutrition could be a serious complication of this procedure, and sometimes it requires revisional surgery. So our aim in this study is to analyze the results of revisional surgery to treat malnutrition after SADI-S. We included every patient operated at our center between May 2010 and June 2010. 15 patients were included, which represented 3.3% of the complete series of SADI-S performed in our center during the mentioned dates. 3 patients had a 200 centimeters common limb, and the rest of them at 250 centimeters. At the primary surgery, the mean BMI was 44.6. At the revisional surgery, the mean BMI was 21.23. The mean age was 54, 60% of the patients were women, and the procedure was performed after a mean of 4 years after primary surgery. As you can see, around half of the patients were operated between 1 and 2 years after the primary SADI-S, and the rest of them between 3 and 11. The mean bowel movements were 5.2 a day. Every patient had vitamin deficiencies and required oral supplements. 7 patients required parenteral nutrition, and 14 patients required hospitalization. After multidisciplinary team evaluation and failure of conservative treatment, revisional bariatric surgery was decided. Among surgical techniques, the duodenal bypass was made in the first operated patients of the series, and we decided to do it to avoid technical difficulties of a second anastomosis at the duodenum. But then, as we gained experience, we realized the elongation of the common channel was a better option. 10 patients were operated with a common channel lengthening, and in 3 of these patients, we also associated a re-sleeve. We did it because these patients were concerned about regaining weight after the reintervention. And finally, 2 reversals of the SADI-S were performed. There were no intraoperative complications, and we found 4 patients with shorter common limbs than they were supposed to. We had 3 Clavien 2 complications in the postoperative period, 1 Clavien 3B complication, which was a patient who had a reintervention because of intestinal obstruction. It's important to note that this patient had a duodenal bypass. Also 1 Clavien 5 complication, which was a patient with respiratory distress who refused to receive mechanical ventilation. And the hospital stay was a median of 7 days. In the long term, after a follow-up of 4 years, every patient gained weight and the BMI increased to 27. The bowel movements decreased to 1.36. Only 3 patients required oral supplements, and only 1 patient required a second revisional surgery. Also a patient with a duodenal bypass. This patient had a persistent malnutrition and intermittent intestinal occlusion. If we analyze the results, we could group patients into 4 possible causes of failure. First, we have the inadequate selection, with 1 patient who developed cirrhosis secondary to hepatitis C and another who suffered from recurrent psychotic episodes of his schizophrenia. In these 2 patients, we performed the reversal of the SADI-S with a good postoperative outcome. Then we have the group of patients with a technical error. These patients tend to have an early onset of malnutrition, and they were operated around 1 to 2 years after primary SADI-S. Then we have the group of patients who had poor adherence to nutritional recommendations and follow-up. 2 of them secondary to an alcohol abuse which started after the primary procedure. In these patients, the revisional surgery was performed lately after 6 to 11 years of follow-up. And then we have the other group of patients, the last one, who includes patients in which we could not identify a specific cause of failure. Just a few words about literature. There are a few studies reporting revisional surgery after SADI-S, and all of them are case series with very well number of patients. Here we can see some studies which report the incidence and outcomes of revisional surgery. As you can see, the incidence of revisional surgery is lower than the reported in our study, but this might be explained because we had a slightly longer follow-up. Most of the studies report a follow-up of only 2 years. The most common performed surgical technique is the common channel lengthening, and no relevant complications are reported by the studies. Now some messages to take home. First of all, adequate selection of patients and type of primary procedure is very important. A standardized method for bowel measurement is recommended in primary SADI-S. Education of patients, of course, is mandatory with a close, lifelong follow-up by a multidisciplinary team evaluation. Early prevention and treatment of nutritional deficits must be provided, and when conservative treatment fails, the revisional surgery seems to be safe and effective, but of course, more studies are needed. The surgical procedure must be individualized, and the revisional surgery should only be performed in high volume centers. Thank you very much.
Thank you very much, Dr. Lasses. Beautiful study. We have just heard from Dr. Sancho Pernaute that they recommend to use a 250 centimeter common limb. And from your study, I have learned that 7 of your 15 patients had 200 centimeters and 8 patients had 250 centimeters. So do you think that there is that limb length plays an important role in the development of this malnutrition? You think that the other factors that you just alluded were more relevant than the limb lengths?
Yeah, well, thank you for the question. We have the first patients with 200 centimeters common limb because they were part of the initial series of the SADI-S. After those first patients were operated, we had a malnutrition rate about 8%. So that's when we decided to make a common limb of 250. But we include all of the patients in this study. So of course it's different. With the 200 centimeter, the malnutrition rate is higher. But right now with the complete series, we have a rate of 3.3%, which is lower, of course. Right now, we, like Dr. Pernaute said, we usually make 250, like for a standard. But then we also have some patients, for example, older patients, patients with comorbidities, with a lower BMI. In those cases, very selective cases, we also use a 300 centimeters common limb.
Thank you very much. Dr. Cao, Dr. Chikora, any questions for Dr. Lasses or questions from the floor?
Dr. Lasses, I enjoyed your paper very much. In one of your slides, you recommended this operation to 2 groups of patients, the younger and the older. And I wondered whether you have a protocol for your limb length for these 2 different age groups.
We have not a standard limited protocol. We try to individualize every patient, but we tend to do a longer common limb when the patient is over 55, for example. But we try to individualize every patient. Age, comorbidities, BMI.
So it's a standard protocol for all ages, but individualized to the patient.
Yeah, we try to do it between 250 and 300.
Are there questions from the floor?
No questions here.
Go ahead, please.
No, we don't have any questions. No questions. Yes,
Okay, Dr. Cao. Thank you very much, Dr. Lasses. Please present the following papers, Dr. Cao.
I believe you're muted.
Isn't there one more paper you introducing, Miguel?
No, Lillian, that paper was withdrawn.
Okay. All right, then it's my turn
Please go
to
ahead.
introduce the next
Withdrawn.
speaker. I'd like to invite Olivia Lovrix to present the association between bariatric surgery and breast cancer outcomes, a matched cohort study. And this is a paper from McMaster University.
Hello everyone, my name is Olivia Lovrix. I am a general surgery resident at McMaster University in Hamilton, Ontario, Canada, and today I'll be presenting bariatric surgery and breast cancer incidence, a population-based matched cohort study. Thank you so much for coming. I have nothing to disclose. So breast cancer is the most commonly diagnosed cancer in women globally. Obesity is associated with 13 different types of cancers, and as we know, obesity rates are rising internationally. Obesity is associated with an increased incidence of breast cancer in women, and it's also associated with a higher breast cancer-specific mortality. While we know that bariatric surgery is an effective intervention for obesity, it's unknown whether weight loss via bariatric surgery eliminates these negative carcinogenic effects of obesity. This study sought to investigate that, with the primary outcome being incidence of breast cancer in women with obesity compared to women who underwent bariatric surgery at 1 year after bariatric surgery, as well as 2 and 5 years post. Secondary outcomes related to cancer characteristics included things like tumor grade and cancer stage in those who did develop breast cancer. So this study used linked clinical and administrative databases in Ontario, which is Canada's most populous province. Databases included the Ontario Bariatric Registry, which includes data on all bariatric procedures in Ontario, as well as the Electronic Medical Record Administrative Data Linked Database. The subjects were women with obesity and no history of breast cancer who underwent bariatric surgery compared to women who did not. They were matched using propensity score for age, breast cancer screening, as well as patient factors like socioeconomic status and healthcare utilization. Cause-specific Cox regression models were used to assess the primary outcomes, and the screening status was with time-varying time-based interactions incorporated into the regression model. So between 2010 and 2016, nearly 13,000 women underwent bariatric surgery who had no history of breast cancer, and these women were matched to non-surgical controls. The average age was 45 across both groups, and they were matched for standardized differences under 0.01 for most categories. The primary outcome occurred more often in the non-surgical group, with an adjusted hazard ratio of 0.81 and a p of 0.01. This was maintained at 2 and 5 years when there was a 30% hazard reduction. So this is the unadjusted cumulative incidence curve of breast cancer after bariatric surgery, or index. So in terms of our secondary results, women in the surgical cohort were more likely to be diagnosed with lower grade tumors, and they were less likely to be diagnosed with HER2 positive tumors. And so while our data did also demonstrate an effect on hormone receptor status, there were too few events and too much missing data, which precluded any conclusions to be formed. Treatments undertaken by the groups were not different between groups, with over 90% receiving surgery, 75% receiving radiation, and less than 20% receiving chemotherapy. So in the study of over 25,000 women, bariatric surgery was associated with a reduced risk of breast cancer compared to women with obesity without a surgical history. This was durable at 2 and 5 years. This is an important finding considering the extensive matching done to account for important patient risk factors, as well as the use of the time-varying analysis for breast cancer screening. This is the first study to our knowledge to do so. The findings here are supported by recent retrospective cohort studies and by 2 recent meta-analyses as well. Potential mechanisms postulated include changes to bioavailable circulating estrogens, changes to local tumor microenvironments, and alterations in hormone pathways. Now, disparities do exist in the effects of surgery on tumor characteristics, which demonstrate competing results across the various studies available, including ours. Overall, while obesity is associated with worse histopathological characteristics, it remains to be shown whether the reduction in obesity via bariatric surgery reverses these effects. Our study here did demonstrate no effect of bariatric surgery on stage of diagnosis, which is contrary to some recent research, but given the many variables controlled for here, the true effect is difficult to determine. So overall, while there are limitations to any study, especially those inherent to database-based studies, this study is important as it demonstrates further secondary benefits of bariatric surgery in the form of primary prevention of cancer. Thank you very much. I'd be very happy to take any questions.
Thank you, Olivia, for a lovely presentation. My question to you is that you found that there was a decreased incidence of low-grade tumors in the group that had bariatric surgery. Was it correlated with the size of the tumor and also correlated with the weight loss?
Thank you very much for your question. So unfortunately, given the limitations of the data that we do have, we were unable to correlate it with size of tumor in particular. Regarding the weight loss as well, we were only able to analyze given the limitations of our registry. And given the registry, we know our weight loss at 1, 2, and 3 years, but we weren't able to correlate specifically per patient as well as on a global scale. So unfortunately, I'm unable to answer that with our data.
The other question I had was that in your control group, did you document their BMI?
So each patient, the cases and the controls were matched to BMI within 0.1 kilogram per meter squared. And so with that, we were able to monitor on a time varying analysis as well to ensure that the baseline weight and BMI were the same at baseline.
Great, thank you. Anybody else have any questions for Olivia?
Any questions here? My only comment, Olivia, first of all, great presentation, nice job. Is with the other study that came out of Ontario, you know, the benefits to these comorbidities and outcomes is something that we as a societies have to continue to promote other than just the weight loss. So, you know, great job on that.
Thank you very much.
All right, if there are no other questions, thank you very much, Olivia, for your lovely presentation. We'll now move on to our next speaker, which is Dr. Adrian Billeter, who will talk about development and validation of a novel scoring system for non-invasive NASH detection in bariatric patients. Dr. Billeter is from the University of Heidelberg Hospital. Thank you.
Thank you very much for the opportunity to present our work about the development and validation of a novel scoring system for NASH detection in bariatric patients. As you all know, liver disease is highly prevalent in bariatric patients, affecting over 60% of patients with steatosis, about 1/3 of them with NASH, while some of them have advanced fibrosis or even already a cirrhosis at time of surgery. The consequences of NASH are also well established, with a rapid increase in NASH-related liver transplantation in the US and the rest of the world. And also one of the issues with fatty liver disease is that HCCs can occur in already non-cirrhotic liver, this being the main cause of non-cirrhotic HCCs. Therefore, the recognition of NASH is of paramount interest in a population at risk. One of the issues is that the intraoperative evaluation of the liver, if it's NASH or just fatty liver, is highly inaccurate. And if we would know that patients who have a high risk for NASH, they can undergo a liver biopsy intraoperatively, and these patients then can be treated and surveyed to prevent the complications of NASH. Also, if we have a reliable screening tools confirmed in bariatric patients, we can also apply that in the obese population in general. Therefore, our goal was to develop a non-invasive, easy applicable score to detect NASH. As you can see here, we made a cohort study with 2 cohorts. First of all, a training cohort consisting of 60 patients, and we gathered a lot of data, basic characteristics such as age, gender, BMI, diabetes, comorbidities, a lot of lab values, but also established fibrosis score, as well as the FibroScan. These liver biopsies were then assessed by expert liver pathologists using the SAF score developed by Vidosa, which reliably detects NASH and also grades the score to allow the diagnosis of NASH. In this cohort, about 45% of patients had a NASH, and almost 10% of them already had advanced fibrosis. Now, we performed a universal analysis followed by logistic regression analysis, and the parameters that went into the score are albumin, ALT, BMI, and triglyceride. And as you can see, each of these parameters itself does not have a great AUC, but the combination with it using this formula shown here to the left allows to make this score, which is AUC with area under the curve of 0.87. This translates into a sensitivity of 77% and a specificity of 88%. An example here is, for example, is IGF-BP1, which is a marker that is recently discussed as a marker for fibrosis. And you can see here in this cohort, the area under the curve is not that bad, but it does not anything to the score to make it better. Therefore, it was excluded. So it is a very simple score, just including albumin, ALT, BMI, and triglycerides. Then, using the validation cohort, we validated the score with comparable area under the curve, 0.72, but with a sensitivity of 88% and a specificity of 48%. It's usual that the validation cohort has less accuracy than the development cohort. And what the important point is that in patients with type 2 diabetes, shown here on the side, the area under the curve is comparable with 0.8, which is rare for most NASH scores, which have lower accuracy in patients with type 2 diabetes. When we compare this score regarding its sensitivity and specificity to detect NASH, here shown including the FibroScan, you can see here the score has a better area under the curve and sensitivity and specificity than all the other non-invasive scores to detect NASH. In summary, we developed and validated easy-to-use, non-invasive, readily replicable, and performable score with good accuracy that detects NASH in obese patients. Also, type 2 diabetes seems not to have an influence, which is not the case in most other scores, but nonetheless, this score needs further validation and also optimization of the formula and independent cohorts, for example, other countries or regions. Interesting would also be non-severely obese patients with NASH, normal weight patients, the lean NASH cohort, if this cohort performs well or not. And also what we will investigate is if advanced fibrosis, F3, F4 fibrosis will also be detected reliably. I'm happy to answer any questions, and thank you very much for your attention.
Thank you very much for your paper, Dr. Billeter. One question is, the cohort of patients that were in your study, did they receive any low-calorie diets prior to their surgery? That is, a liver shrinking diet?
Yes, usually we provide the patients with a low-calorie, protein-rich diet before surgery, but we didn't do that for all patients. So this is kind of balanced out in this cohort.
And with your scoring system, Was there any observations made on the appearance of the liver at the time of surgery, and did that correlate with your score?
We didn't do the assess that prospectively, but there was one patient that we knew had liver cirrhosis from the gross aspects of the liver during surgery. But as you have seen, a lot of patients, like 10%, had advanced fibrosis or cirrhosis, and those were not detected as such. So I would say that for most patients, surgeons are not that great, and there is actually a study who investigated that, and they found that surgeons have like 50% rate of hitting the right spot. So you might as well flip a coin.
Okay. Anybody else have any questions for Dr. Billiter?
No one here. No questions here.
Professor Shikora, Professor Miguel?
Not me, thank you.
All right. Well, thank you very much for that paper.
Oh, no, okay.
There are no further questions, then thank you very much. We'll move on to our next paper.
Here's a question.
Lilia, no, there is not a question, but we're gonna need to do a 5-minute break if you are so kind before presenting the last paper. There is a local thing, so we need to 5 minutes and be back.
Okay, we'll come back in 5 minutes.
Get a coffee, bathroom break.
Okay, Professor Kao, we can restart.
Okay, well, welcome everyone back after your 5-minute break. It's my pleasure to introduce the next speaker, which is Bahram Abudaya, who's the Professor of Medicine, Director of Advanced Endoscopy, Vice Chair of Innovation from the Mayo Clinic in Rochester. Professor Abudaya will be speaking on endoscopic sleeve gastroplasty for obesity, results from the multi-center ESG randomized international trial, or the MERIT trial. Thanks, Bahram.
My name is Barham Abudaya. I'm a professor of medicine at Mayo Clinic in Rochester, Minnesota. It's a pleasure to present to you results from our randomized controlled trial on endoscopic sleeve gastroplasty. These are my disclosures. I would like to start by acknowledging the medical lead for the trial, Dr. Nathan Zendel, the medical proctor, Dr. Manuel Galbao Nieto, my co-PI, Dr. Eric Wilson, and the MERIT investigators. In 2021, we still have a significant gap in the management of obesity and its comorbid conditions. Therefore, we need more therapeutic options that are organ sparing, safe, and effective, results in minimal disruption to the function of the organ, and results in significant weight loss with little or no long-term negative consequences to health. Therefore, we investigated the use of the overstitch endoscopic suturing device to have a perioral approach to reducing the gastric reservoir into a tubular restricted endoscopic sleeve gastroplasty as shown in this diagram. This affects the accommodation and the emptying of the stomach, results in improved satiety and satiation and thus weight loss. Note from the MRI imaging shown in this video clip that the innervation of the stomach and its vascular supply are intact, thus the endoscopic sleeve gastroplasty represent an organ-sparing approach to weight loss. We conducted a large randomized controlled trial in 9 US centers involving both bariatric surgeons and gastroenterologists, both in community and academic practice. The trial enrolled 208 patients with a body mass index at baseline of about 36 kilograms per meter square. The primary goal of the trial is to meet or exceed the threshold set by societies of achieving 25% excess weight loss at 12 months with a differential compared to a lifestyle arm of about 15% and an incidence of serious adverse events of 5% or less. We also wanted to investigate the durability of the response and the impact of endoscopic sleeve gastroplasty on comorbidities, including hypertension, type 2 diabetes, metabolic syndrome, and GERD. This is the randomized portion of the trial. At 12 months, the ESG arm achieved 49.2% excess weight loss, thus exceeding the threshold of 25%. The differential compared to the lifestyle arm was 45% excess weight loss, exceeding the target of 15%. We had 77% responders rate, and the total body weight loss in those who responded was 16.3% at 12 months. Year 2 of the study was impacted by the COVID-19 pandemic. Thus, however, I'm happy to report that despite the pandemic, the crossover arm achieved similar weight loss results at 12 months after the crossover. And those who underwent endoscopic sleeve gastroplasty in year 1 maintained the vast majority of weight at 2 years after the intervention. We had 3 serious adverse events, including a perigastric abscess that was managed with endoscopic drainage and antibiotics, a case of upper GI bleeding that was managed endoscopically with no need for transfusion, and a case of malnutrition that required reversal of the endoscopic sleeve gastroplasty endoscopically. No patient in the trial required surgical intervention. We had no ICU stays, organ failures, or death. The rate of serious adverse events was 2%. From a denominator of 150 patients undergoing the procedure. The procedure was mostly done as an outpatient. However, 6 patients or 4% required hospitalization for conservative management of accommodative symptoms. The endoscopic sleeve gastroplasty had robust improvement in multiple important comorbidities, including metabolic syndrome, that improved in 82.8% of the ESG cohort compared to 35.4% of the standard of care cohort. Type 2 diabetes improved in 35% of the ESG cohort, with 35% achieving partial or complete remission, compared to the standard of care where 40% worsened, 20% improved, and only 6.6% had partial or complete remission. Similarly, hypertension improved and quality of life in all measures as shown in the slide. Any procedure that impacts the stomach, we have to be worried about the long-term consequences of gastroesophageal reflux disease. Therefore, we monitored carefully for GERD using standardized questionnaire, which is the GERD HRQL. As you can see in this figure, that GERD improved both in the lifestyle and ESG arm. Numerically, it was more so in the ESG arm compared to lifestyle, but that did not reach statistical significance. However, the more important point that endoscopic sleeve gastroplasty improves, not worsens GERD, at least at 52 weeks. So in conclusion, endoscopic sleeve gastroplasty is an effective, safe, and durable intervention for weight management with a favorable impact on disease comorbidities. And with that, I thank you for your kind attention and conclude my presentation.
Thank you, Baram, for a very interesting presentation. My first question to you is that your patient with the abscess, was there a cause for that? Do you think it was a perforation? That was my first question. And secondly, do the patients receive antibiotics as part of your protocol?
The patient who had an abscess probably was a small microperforation in the proximal part of the stomach. It was a very indolent course. That means the patient was just having some fevers intermittently. We did imaging and we discovered it. So it only required endoscopic drainage. But all patients who undergo the endoscopic sleeve gastroplasty do get antibiotics prophylaxis during the procedure to prevent such microperforations causing problems. It's a very rare event. In my clinical experience, it happens in definitely less than 1% of patients, but antibiotics is very effective in preventing this.
Thank you. And my other question is that with your endoscopic sleeve gastroplasty, I know it's quite tedious putting all the sutures in. What's your average time per procedure?
Yeah, so traditionally the average time now is about 45 minutes to complete this procedure, and the average number of sutures is about 8 sutures. So it became very quite efficient to do this procedure, and I think the technique continues to move forward and the efficiency continue to increase. So hopefully this will be in the neighborhood of 30 to 40 minutes procedure.
It certainly does require a good amount of practice, a long learning curve around your endoscopy skill set, and certainly using the device to get efficient at it, to get it below an hour.
May I ask a question? Hello.
Yes,
Yes, please.
Baram, great results. I've heard you speak several times now, and every time you just blow me away with the results that you and others have achieved. Right now, the people doing this operation are the best of the best, the cream of the crop, you, Chris Thompson, Galvo, and others. But how are we going to control this when it becomes open to anybody who takes a weekend course and then books 4 cases for Monday morning and doesn't get the good results you get? And it hurts not only the patients, but all of us in the field. Is there any efforts underway to kind of regulate it, credential it, where you have to do so many cases to be able to do it on your own, or anything of that nature down the pike?
Definitely, Dr. Shakura, that's an excellent question that really needs to be addressed. Definitely, they're going to be needing a threshold credentialing process to do this procedure and ensure safety and quality of the procedure. The good thing about the procedure is it's scalable procedure, could be done as an outpatient, and it's teachable. That means both bariatric surgeons and gastroenterologists could do this procedure. Now, a point to make that the MERIT trial was designed to be generalizable trial. That means not everybody who participated in the MERIT trial were expert in the procedure. We had a lot of people who just started their ESG during the MERIT trial, including both gastroenterologists and bariatric surgeons, including academic setting and community setting. So by design, the results that we're showing should be generalizable because it involved both community and academic, and both experts and people who just recently started the practice of ESG. But going forward, we definitely need to standardize the education and the credentialing of this procedure to ensure good results and to ensure that we're taking care of the patients safely.
Thank you.
I have one question.
Please.
Congratulations, very nice paper, Barham and all the team. I wanted to ask, you said 16% of the responders. What do you meant by that? The excess, the total weight.
Yes. So the primary endpoints for the trial were designed to meet the threshold that both the ASMBS and the ASG defined in their statement of what they consider an effective endoscopic treatment for obesity and metabolic complication. In their statement, they defined the threshold for clinical trials to be 25% excess weight loss. Now, I don't like excess weight loss, but that's the definition a priori defined by societies for these interventions. So that the study was powered based on excess weight loss, and it doubled that expectation. So we got 50%, and the threshold was 25. And it's speculated in these guidelines is to be differential from lifestyle arm of 15%, and we got more like 45% differential compared to lifestyle arm. Now, we do have total body weight loss, and we definitely present that total body weight loss. More or less, the total body weight loss was about 14% for the entire cohort. For the 77% responders, that mean they reached the 25% excess weight loss, the average was about 16.5 total body weight loss.
Ah, okay. Okay. So the mean was 14 and 16 for the
16.5.
Yeah, because that's what we are seeing. I'm seeing that the mean is 14, but we still have very good responders, but still there's a group that and if they fail, they completely fail. It's a disaster, and they definitely they don't like the procedure, and they change and they move and everything.
Yeah, so that's why the presentation was for the responders of the 25% excess weight loss, which is 77% of the cohort. And this cohort lost 16.5% total body weight loss. The whole cohort was about 14% total body weight loss.
And another question was, we've had diagnosed only one pneumoperitoneum, a patient that came back with abdominal pain, and she had quite a big pneumoperitoneum, but she went very well after 24 hours, went home. But I feel that there's much more than that. And I like look in the sky when the patient says, "Oh, I have pain," and I said, "Oh, it's going to be okay." And I think the pneumoperitoneum is much more common than we think. I think it's not. It doesn't have probably important clinical implications, but do you think? I didn't see any in this series.
So this gets to an education point too, Camilo. It should be CO2 peritoneum, and there will be translocation of CO2 across the suture sites during the suturing. And using lower pressures when you're doing it helps. So as experience does improve that. But I think a very important educational issue is to make sure that you're using only CO2. And we still have lots of endoscopists out there that don't understand. Turning the air valve on at the same time you turn the CO2, you're inflating air. And if they get nitrogen in their peritoneum, it's going to last for a while. And so some of those events are due to poor education, poor setup of the endoscopy equipment, and can be avoided. But temporary CO2 in the peritoneum will resolve quite quickly. And when you see incidents of these lasting for a period of time and you really start to look at it, you'll find that most of the time someone has hit the air button and turned on, and that's resulted in nitrogen being inside the abdomen, and it results in longer stays. So important educational thing that we need to focus on as this procedure grows.
Hi, Marcos Berry from Santiago, Chile. I would like to know your comments about this. We have seen in our group about 20-25% of non-responders. I mean, after 1 year, they do not lose weight, they're unhappy. The cost is the same as a sleeve gastrectomy. So they come to us and say, I pay the same, I'm not losing that weight, I'm unhappy. Number one. Number two, when we do some of them follow-up endoscopy, it's very common to see 1 or 2 stitches are completely loose. And it doesn't correlate exactly with weight loss, but it's a concern. So your comments, please.
So good points. There are non-responders. Previous studies have shown this vary between 20 and 33%. It's important to know that when you have a non-responder, it's usually presents itself early, like within the first 6 months. So if a patient's not doing well with an ESG, it makes sense to go and reevaluate them early in the process. You don't need to wait 1 to 2 years and convince yourself, oh, they're going to get better. So if they're not responding, they're not going to respond in a fairly early fashion, and it gives you an opportunity to evaluate and consider whether other interventions are possible. It's very important with this procedure. It is going, the anatomy is going to slowly relax to some degree over time. These sutures will loosen to some degree over time. But this study and others have shown that there is at least a reasonable 2-year durability to this. It is revisable. You can retighten it. More studies and data needs to be collected on that. And it is convertible, but it's also very important to educate the patient, since you cannot predict the responders before the procedure, that they need to be committed to this process and this procedure for a minimum of a year, but really closer to 2 years. Because converting them to another procedure, it's going to take some time. It may take time for things to dilate up so you can safely do a sleeve gastrectomy. Now, as far as your cost argument, I think that's very regional. It depends upon the device and what's your cost for sleeve gastrectomy. In our practice, this is definitely cheaper than a sleeve gastrectomy based upon how we price it for patients. So I think that's a regional argument depending upon your access to the equipment, and with time and growth, of course, these devices will continue to get cheaper and be more competitive with in all regions around the world, I think.
One point I would do to add to Dr. Wilson's point is the concept here is you're preserving that organ, whether it's innervation, vascular supply, or structure. That means you could have options in the future. You could retighten it, you could convert it. Yes, there's going to be non-responders. The result is not as robust as the sleeve gastrectomy, but they don't need to, because they are a different population, number one. Number two, it's covering an unmet need with people with mild to moderate obesity. And three, it could be complemented with medications and down the line with surgery if need be. But a good 60% of the cohort will maintain good durable weight loss over the longer term. Some will struggle, you add medication, you retighten. Some will need to be converted to bariatric surgery. The beauty of it, it's one procedure, no implantable, does not burn bridges for all of these options for the patient, and fits a model of chronic disease for a disease that is chronic.
And Barb spoke on this, but the patient population is a different patient population than the pure surgical patient. Really fits between BMI 30 and 40 quite well. There's been studies already done, as we all know, around the world that have compared when you get higher BMIs, you start to see a difference in weight loss that's quite substantial between sleeve gastrectomy and this procedure. So it just doesn't really need to compete with surgery.
Thank you, Eric. Thank you, Barham. We're going to finish this session thanking Scott, Lilian, Miguel. Thank you very much. And we're going to thank Carl Pesta for being our local host for this. We finished the day, the virtual meeting. So, and again, I want to thank advisory meeting. Our IV guys were amazing today. Patient with us, Manuela, Lilian, Scott, Miguel, everybody who's been helping here. Thank you guys for being here. Enjoy Miami. And some of you can stay the 10 months we have left for the next meeting. You are all invited to stay in the city. This is a marvelous city. So if not, I'll see you in Miami next year. Thank you again, everybody. Good night for some, good very early morning for some. And thank you very much, you all.
Thank you.
Thank you very much, everybody.
Thank you very much. Enjoy Miami for those of you who are there.
Safe travels, Lillian, Miguel.
Back to the home.
Sure.
There.
Likewise.